Hello. Good evening. Good Hello?
Yes, Dr. Aman, please go.
Hello. Good evening, my dear vascular surgery family in Egypt and all over the universe. It's an honor to welcome you all in our vascular online training second webinar meeting. Nice meeting you all, really. Before we start, let me introduce our great panel. I want to welcome Professor Pierluigi Antoniani from Italy, Professor Nobni from Germany, Professor Martin Marsh from Bahrain, Professor Fernando Vega from Mexico, and Professor Luis Fernando and Alfredo Galvo and Felipe Maprim from Brazil, Professor Ashdit Dada from India, Professor Eugenie Berzoni from Russia. Hello, thank you for joining us today. I want to thank Sigvaris Group and Dr. Mahmoud Al-Ghadban for sponsoring this great conference and meeting online. Now I am honored to introduce our famous and brilliant speaker, Professor Munir Nazal. He's a very famous and eminent speaker. Professor Munir Nazal, professor of Toledo University Medical Center in the United States. He's a professor of surgery and chief of division of vascular and endovascular surgery, governor of the American College of Surgeons. He has a lot of publications. I know one of the most important one that may affect my practice in vascular surgery that was published in the Journal of Vascular Surgery, talking about the contrast enhanced public surveillance after EVAR, enhanced efficacy using continuous infusion technique. This paper really improved my practice very much. Also, Dr. Mahmoud Salah from Saudi Arabia just arrived. Welcome, sir. Thank you. And now I will leave the mic for Professor Munir. Please, sir.
Well, am I unmuted? Yeah. Thank you very much. Really, I enjoyed the meeting last week. Unfortunately, I had to rush for a procedure. I could not finish it. So tell me if the images are, do you see it well?
Yes, Dr. Munir.
So good. So I was supposed to talk about aortic emergency, but then I changed gears last week because aortic emergencies, it's written everywhere. And we talked about it. I'm sure we can find a lot of literature. I decided to discuss something for the future, which is going to affect the way we practice medicine, surgery, and everything. It is artificial intelligence and machine learning, and specifically in healthcare. It is everywhere. It's in healthcare. The first time I was introduced to the subject was when I was doing my MBA, and the professor said, a lot of you will be obsolete because of machine learning. We didn't like that, of course, but then he showed a picture of a drone taking images for the traffic in Los Angeles. He said, 3 people lost their jobs here. The flight attendants and the helicopter pilot, the photographer, camera, and the station person. And they were all replaced by a drone. So it's why I said I will do that as part of the VOT. Hopefully we can interact. Before I go that, was impressed with this meeting. We talked to Khalid and the board of Venous Forum. We are going to start our meetings like that. and it will be the 2nd of May. I'm sure we will use your help as we are going to need that. The second thing, I want to introduce you 2 things which I'm working with and on. The first one is the International Federation of Healthcare Thought Leaders. This is a new organization. It's international, from the US, Germany, some actually members added from the Middle East, South America, to discuss issues related to healthcare and policies and advances and education. One of the ideas we came with, which was actually presented about 1.5 years ago, to have an online medical school. Everybody said at that time it's a crazy idea, cannot be done. But now we are working on it to reach that stage. This is part of what we talk about, the artificial intelligence and machine learning. The International Federation of Healthcare Thought Leaders is started in Harvard in the US after a course attended by a number of physicians and leaders in healthcare. One of the committees, education, the other committee is artificial intelligence and machine learning. I lead that committee with another person from Europe, and hopefully we'll come with a lot of ideas in that. Another company that we are working with is called Surgisphere. That is introduced, built, and established by a vascular surgeon. His name is Sapan Desai. And we met about 2 years ago, and we found that we have the same interest in artificial intelligence, and we started writing papers together. One of the papers we wrote about how to predict mortality in COVID virus, and it's going to be published soon in the New England Journal of Medicine, and another paper in the Lancet. So only we could do that because of artificial intelligence. This is my introduction. Amazon, Netflix, all of them are artificial intelligence. You notice actually, and machine learning, if you go buy something from Amazon, the first thing it will tell you, it will show you everything related to that thing you were looking for. Not only that, go open your Twitter after that, and you will see all those ads related to what you were looking on Amazon if you use your phone or if you use your actually even email. That is the same email for the Twitter, the same as for the Facebook, and they keep repeating themselves. This PowerPoint, when I was doing it, the machine, which is the computer, kept telling me these are the suggestions, how to do your PowerPoint. So this is machine learning also. I suggest actually that we all, bright people, being in this field, should know something called average is over. So in the past, we could live if we are an average person. The COVID virus problem produced the evidence now, average is over. So the other one is the 4th industrial revolution. It is not oil, it is not technology. The industrial revolution is actually data. So the future is data or data. It depends if you are from the US or from England. And the problem data is going to be much more with the 5G. The problem with data also is going to be a huge number. It's like oil, but the problem is what to do with that data. That's why we need really to know what to do with that data. In 2016, Schwab Close wrote in his book that these are the jobs that will be impacted by machine learning, automation and machine learning. And these jobs include telemarketing, tax preparation, etc., which means he thinks in few years, 99% of telemarketers will be machines. Guess what? We are close to that. And these are the other ones. So I'm going to talk in this outline. These are the subject, and I will introduce a study we are submitting actually to JAMA again about machine learning that we came up with in here in the with our division in the US. Let's take a scenario. A 40-year-old patient come with abdominal pain, nausea, vomiting, no guarding, tenderness, fever. In the past, You see the patient in the ER, do X-ray abdomen, repeat exam, do CBC, admit the patient, keep examining the patient, etc., etc. Nowadays, you do the CAT scan in the ER, admit the patient until the patient is seen by the attending, and you get the report from radiologist. Then you decide, should you go to surgery, no surgery, or repeat the CT scan? You know what's the future? You do the CT scan in the ER, you get the report in 5 seconds, and you get also a report telling you go to surgery. The patient doesn't need surgery. That is machine learning. That's artificial intelligence, which means it uses a huge number of data and put them in a machine. Somebody process that data and then produce an output. And that processing through a process called algorithm building and negotiation. That's what you need to do. You need a very, very, very good statistician to do that. That's all what you need, but also you need a huge amount of data. It is the ability of the computer to approximate conclusions for you. And it has its advantages, it has its problem. So without a human input, this machine will not work. This is one issue. But the human input is the problem, because actually the human input can be a problem. If you want to cause damage, you can cause damage. If you can help, you can help. So in medicine, artificial intelligence in medicine is used in issues of great interest for people that needs a lot of data. What's made it also possible, because we have the EMRs. Everybody is putting data on those EMRs, like the Surgisphere that my friend Desai has. There's 1,000 hospitals in that company giving their data, and we are looking for more. Actually, we are looking to increase them from Europe, the Middle East. I'm not a partner of that company. I'm just helping him because of research. So anybody who has an EMR data in any hospital wants to be part of it, just email me and we will, it is free, no money paid at all. So you put all the data, images, and come up with the conclusions. So it has many phases. The first phase is the input, and that applies to all inputs, garbage in, garbage out. So you have to decide what data you are going to do. Then you have to confirm epidemiologically that this data is proper, and then do statistical confirmation or analysis, then produce the algorithm, then you produce the output. So this is, in a simplified form, what it is. The process of the machine is what we call algorithm formation. We call those algorithms really as black boxes because it's a secret for any machine. Are they independent thinkers, the machine? The answer is no. So far, of course, they might become in the future, but they are not independent. We need data. We need intelligence of the people who are running those data. But the more the data you produce, the more the intelligence. So it is not autonomous creative. It is actually spontaneously can produce result if you ask it, but it will not produce it unless you ask the result, and cannot determine a new way to respond to anything unless you decide as a human how to do it. But I guess in the future, all this is going to change. When I say the future, it's very fast. It's coming actually soon. So why we call it artificial intelligence? It's trying to do what the human being cognitive functions is doing, but the problem is still needs a human being. This is one issue. The advantage though, it is multiple layers, millions of times faster than a human being. So it takes different data, put them together, and then give you some information. So that's what we call a paradigm shift in healthcare. And it's coming whether we like it or not. They are not independent, but I say they will be independent in the future. If you look in artificial intelligence, actually, many people started writing about that. This is the way it goes. So you have the input for the data, then somebody will come with the statistics like that. And that statistics is the area which we call the algorithm in the middle. Then it gives you output. use this output, which is information, to come to your outcome. Sometimes it's not one layer, it's multiple layers, like not only one statistics, one to the other, and we keep this, we call this deep learning, because it becomes like the human brain, from one layer to the other until you go to the decision process. And the more the layers, the more difficult it is, but the more accurate and the data, and the more usable the data. And it is a very complex process. And look at the number of articles in the literature coming about artificial intelligence. Hardly any article. 2013 is about 20, 25 articles. In 2016, there were 216 articles. I bet you now it's more, 250 articles. It's thousands of articles now. And these are the areas that artificial intelligence is, different languages they use. We don't need to go through that. The problem is it a black box? Yes, it is a black box. It is a black box, and it can be inscrutable, which means nobody knows how it was done. Even it is unsupervised learning, can give you information, but you don't know how it will come that information. You can decide what to predict. You can manipulate the data. You can actually decide the result in advance if you want to do that. And this is danger in it. For example, you can actually trick the data, especially if it is images, like in one of the Google experiments, the goats were thought it's dogs because you need more data to say the information. I'm sure many of you were watching the COVID in China when the police were having those helmets on them, which can actually tell the name of the person, where he lives, and if he has fever without touching them. This is, again, artificial intelligence, millions, billions of data giving you information. The problem, this algorithm is a black box. Nobody is ready to release that for you, because once you release it, anybody can reproduce it. This is where the danger is. You can decide what to do with that black box. You can get a real output, but if you can have a destructive output, you can get a destructive output. Any question now? This is the introduction. Did I lose you?
I'll take the chance to see what's going for questions. I'll ask the panel, please.
Can I ask a question?
Yeah.
Yes,
Samer هنا.
Samer.
Yes, Samer.
Yes, Samer, please.
I think the most advanced, artificial intelligence now is the autopilot. I think it's a big example of, artificial intelligence. But the problem with artificial intelligence, they cannot go out of their comfort zone, which is the data. They have a data, and whatever the data tells them, they get conclusion. And this is different from a human being. Human being, no. Sometimes data different, but the feeling, you have a feeling, you have like.
So we will cover that. We will cover that in this part. Yes, you are right.
Okay. All right. I will wait. Sorry. So
then perhaps I can continue until we go to a stop before our study.
No, there is a question, Professor Munir.
Yes, sir.
Yes, a question from Dr. Ayman Al-Asir. He said, robotic EVAR looks to have an important role in the future. Do you like to report on using robotic arm in fenestrated EVAR? So
I'm coming to the vascular uses. One of them actually endovascular in general can do that. Like Magellan, I'm sure many of you know about the Magellan robot. You sit in your control room and they do the procedure for you.
Okay.
You just draw the map to go to a renal artery, draw the map on it, and you sit, the wire goes in, the stent, there's nothing difficult. Any angle is okay. As long as you draw the wire, the machine does it.
Okay, brilliant. If any of the panelists have a question, there is a command, just raise your hand and then the mic will open. The mic is open for Professor Mahmoud Salah. Do you like to ask a question, Professor Mahmoud?
Can you hear me?
Yes,
Yeah,
we can hear you very well.
Yeah. It's nice to hear you, Munir.
Oh, thank you, Mahmoud. Sorry, we could not see each other.
No problem. Last time I was in the States, I met a guy who was working in the artificial intelligence, and he mentioned to me, we had a long discussion about this. He mentioned that in the States, they reached a dangerous point that the machines are collecting data and they don't know what the machines will do with this data. The machines are getting the data by itself. I couldn't understand this, or I couldn't even imagine. So do you have any comment about this?
So, of course, I cannot tell you all the secrets about it because these are secrets for the companies, but I can tell you, yes, they are collecting data as we talk now. Somebody knows that we are talking. Actually, you don't have to open your camera to be seen. And the data is collected in large volumes, but as I said at the beginning, nobody knows what to do with it until somebody comes with an idea. Then it can be used. Yes, you're right. And you know the future coming with those chips that will go under your skin, you are done. We are all done. It has to go, otherwise you cannot go to the bank, you cannot do, these are all machines actually. Yeah.
Okay, we can continue the second part of your great lecture.
So we will talk about in some areas. One of the areas that is started with that needs a lot of data, genes. So, you know, we go look for the gene for cancer, gene for atherosclerosis. And then when I define a gene and we think we had all the knowledge, the problem with genes, there are millions of them, millions of combinations. There's no way on earth one gene can be controlling everything. This is where genomics actually can be fully helped and served by machine learning. But sometimes the data variations cause a problem and you can reach actually erroneous conclusions like this. In a study, they could not actually continue with the study because the machine learning gave the wrong interpretation and the wrong recommendation for chemotherapy, and they canceled the study. So the problem, if you don't decide on the equations very well, you get the wrong data on those cases. How can we trust the machine? We have to trust the machine because now it's coming in the future with all decisions done and made by the machines. Yes, it can be abused, but anything in life can be abused. So the standard we use is still, I keep saying, is a black box. Actually, even in medicine, is becoming a black box. Nowadays, we know the machine defeated the standard of medicine and the standard of many areas like chess. Machine is better than humans, Jeopardy better than humans, law, labor, machine automation, furniture assembly, investment advice, all these can be done by machine. Imagine for investment advice, you go to a human being, based on some data, give you an advice, but the machine can collect much more data. If you go to a factory, you have one or two only workers in the whole factory, everything is like a machine. In medicine, these are the areas where there is a lot that's going: imaging, dermatology, diagnostic, pathology, ophthalmology, drug discovery, investment in medicine also. Advice is going like which company you need to go to invest in because they have a future in medicine. Devices for monitoring health and for delivering a treatment, we know the wearables, they are all over. For example, a study done in Ontario, they found the machine predicted with high accuracy infection in premature infants much earlier, about 48 hours before infection occurred. So they managed to predict that this neonate will get infection. No human being could do that, except based to some extent, perhaps based some criteria you might. So the researchers do not know how, but the machine managed to do that actually and determine the onset of infection, which is very abnormal. Wearable device, I'm part of a study actually. One of the companies came and gave us watches, gave us iPads, they want us to try it. We took it. So these wearable devices that they can predict what will happen to you. So they can monitor you. The company is in Colorado, and we are all over the United States. They monitor everybody, and they tell, for example, you have this and that, and they communicate with you. And nurses, authorized nurses will call you. The questions are, the artificial intelligence doctors, are they going to be replaced by, to replace the human doctors? It can. I can tell you in radiology, it did almost. You know, most of the readings in radiology, and you will see that there is a 98% accuracy in mammograms, 98 to 99% in CAT scans, and so on. As Samir said, there's a huge amount of data. We don't know what to do with this data, but it is collected. It's waiting for somebody to put this data together in order to reach a conclusion. It will assist in clinical practice, and I will show you how. It will assist in accuracy based on feedback for the treatment. It will give you up-to-date information. In the EMR, I'm sure many of you using it, when you write a medicine, immediately a flash comes, the patient on this drug, it will interact with it. Are you sure you want to continue? You override it if you want. So this is all machine learning. It reduces the diagnostic and therapeutic errors. It improves and decreases the health risk alerts, and it will actually improve accuracy and assist in decision making. All these actually are going on nowadays. And these are where we are doing a lot actually. In 2016, most of the machine learning was in imaging, genetics, electrodiagnostic, and so on. I'm going to skip genomics because we talked a lot about genomics because it's a huge amount. The areas that taken most of the advances nowadays, as you could expect, is the diagnostic imaging, because you put a lot of images and you read them, the machine can do that in no time. Electrodiagnosis is another one. You all know that an EKG can come up now with a report. It tells you what's going on. Genetic diagnosis, it is something huge. Clinical laboratory, mass screening, all are actually being used as part of machine learning. One of the areas that will advance is actually the genetic RNA and others, and it predicts who will get a disease down the road based on that. And that's dangerous, by the way. In areas where they have insurance, they will insist they want your genetic data. Then if you belong to that group that you might get a disease, they might not give you insurance. And this is one of the problems we will face in the future. Again, this is the same, but I want, again, neoplasms, nervous disease, cardiovascular, urogenital, pregnancy, digestive, all these nowadays having actually artificial intelligence usage in them. The biggest ones, neoplasm, because of genetics and the others. So it diagnoses cancer, predict breast cancer, diagnose Parkinsonism disease, image analysis, chest X-ray report, and diagnosis of peripheral vascular disease with 90% accuracy now. Classify patients of the cerebral ischemia, decide how to treat stroke, decide what is actually the best performance of the patient, how much TPA dose should give the patient to reduce bleeding, and predict 3-month outcome analyzing certain condition. Much better than a human being, 99% accuracy. So this is a study actually we did here in our hospital. So we said we have a huge number of data. We have access to it, which is 40% of the hospital admission in the United States. Let's see if I can predict who will get amputation in patients who have diabetic foot ulcer or diabetes. And this is the first paper we did. It's actually submitted and it's accepted for presentation, but we submitted publication direct. And this is done by actually residents and statisticians with the help of the physician to tell them what we need. We looked at the data. I'm not going to go through it in details. A huge number of data, as you can see. We looked at the changes between people who got major amputation, minor amputation. We classified the data based on that, based on insurance, based on symptoms they have, based on associated conditions, see how much data we put in. And then we found what are the 10 most important factors that contributed to amputation. And we gave them a covariant or odd number. And these are the factors. Gangrene, like if somebody comes with a gangrenous toe, systemic infection, peripheral vascular disease, osteomyelitis, paralysis, and so on. And we weighed each one of them to determine what is the specificity, what is the accuracy of what we are looking at. We looked at the prediction, sensitivity, specificity of each one, and then we boosted it by 10 times to see if we can change the data. And then we came to the most important 5 factors: gangrene, osteomyelitis, systemic infection, peripheral vascular disease, and weight loss. So these are the most important ones. And then again, we weighed them again to make sure the data said, this is the analysis, as you can see. You start with one, put all the combinations, and see what is the risk. Then measure it by histogram. Try it again. Do it again. 3rd time. Then you do neural network. The first one, very simple. Then we did not like that. We want multiple layers, a 3rd layer. And finally, we found these are the sensitivities for each one of those. And if the combination, and we have an app. This is the app. I'm not, yes. Yes, this is the app. Hopefully it will work. It is published. It will be published soon. Give me a second. It will work. It takes a while to open, actually. So the app, you can use it in the clinic using the data, the huge number of data, the artificial intelligence we talked about. So if somebody coming with a diabetic foot ulcer, the chance of amputation probability 0.006. Let's say he had gangrene one area, became 0.137, 2 times the one who has an ulcer only. Let's say he has osteomyelitis also. Now became 1.68 times diabetic foot ulcer and 99%. Systemic infection, 4 times. Let's say all of them. What will happen if we do all of them? These are the old factors. So this person will have 7 times the possibility of an amputation compared to somebody who did not have them. And this person who have all those problems has a chance of almost 50% to be amputated. So this is artificial intelligence. So you put it in an app, the patient walks in the room, examine the patient and tell him, this is your chance of amputation. Perhaps we can change that if you help us change that. And this is what we call machine learning. Any question here?
It's fascinating. It's fascinating. Let me jump to take the first question. Regarding the success in intervention radiology with using AI, artificial intelligence, they have reached a stage that they are more accurate in diagnosing cancer with mammogram than actually intervention radiologists. Can we do this with vascular angiogram? Can we have the same AI in vascular practice? Because I have a few experience maybe 10 years ago, but at the moment there was no software or data collection systems that we have nowadays. So what's your opinion, Munir?
So I can tell you, for example, if you have a large number of data and you see a pathology and then you want to say what is the best treatment, yes, it can be used. And it's coming. The paper that Ayman was talking about, prediction of healing using artificial intelligence. That's right. That's what it is. Prediction, if you endovascularly open 1 vessel, 2 vessel, 3 vessel, is it the flow, what it is? We predicted actually healing in a huge percentage of patients compared to the human beings. There's no comparison even.
And is your mobile app is freely available or you only have the access to it?
No, once we have the publication. We cannot, so it's going to JAMA. Once we publish it, hopefully it will be okay. But it is available. I can send it to you. I can really share it with you one time. Perhaps let me go back to it. You can actually write it now.
Oh, that's very good. Let me open the floor. Professor Ayman, do you like to open the floor to panelists to ask a question? If you have a question, Professor Victor Kanata, Martin, Professor Mahmoud Salah, Samer, do you have any questions from the panelists? We can open the mic. Victor?
Martin?
Okay, this is Dr. Kanata. I have something very nice presentation. I think the future is trying to just work together and have something. In the same way that Omar asked you, do you think that we will have some improvement in the area of vascular surgery and in the area of vein treatment and artery treatments for the patients?
So it will be a lot of improvement in diagnostics and prediction.
Yeah, in diagnostics as well as treatment to have
Yeah,
an idea.
yeah, prediction and prediction.
Prediction of healing.
Yes. So for example, let's say venous ulcer, it will give you what to do. And it will predict the healing if you do certain things in it. What am I going to do? Actually, we are working on 3-4 projects. One of them is healing of ulcers in patients with obesity. We are trying to, we found that obesity is actually preventive of amputation. We don't get amputation a lot with obesity. So we are putting all the data now in the machine learning to see why. Is it the obesity or is it other factors with it? So this is where machine learning helps. So it helps in the decision-making and reading and suggesting a treatment for those patients. It will help a lot, yes. Remember, vascular surgery is vascular medicine. It's not only surgery.
Yeah, that's right. Okay, I think Dr. Martin wants to get a question. Please, Dr. Martin.
Oh, thank you and welcome everyone. Munir, excellent topic. And I guess this change of your topic was amazing. And you have proven yourself as a visionary as well. For the last 2 years, actually, I'm starting the first lecture with my medical students talking about data, because it's very obvious the next decade is going to be a decade of data, as you said. And unfortunately, it's not going to be only good. You are talking about the benefit, and there is no doubt that we have to use artificial intelligence. There is no doubt about we have to use the machine learning. It's just the way how we're going to do it, and it's gonna bring a lot of ethical and practical problems. The problems we have never dealt before with, you know. And the main issue is, Mahmoud and Samir, they already touched an issue. The first, it's gonna be too much data. And there is gonna be, you know, these machines, they will know about us more than we do know ourselves. And the main issue will be the ownership. And I guess we have to put it right from the very beginning, because it's not very clear who's gonna own data about yourself. Yes. And it's going to be a big deal. It's going to be a big problem, because for a time being, the majority of the data is owned by the private companies, by Zuckerberg and the guys from the Google and Amazon. But I don't think so. They're supposed to be the one who owns the data about you. And because it's going to be very easy to manipulate us. And it can be abused in a very profound ways, like Munir mentioned, you know, the insurance policies. It might affect the employment policies and many other issues. So this is just a comment that it's very important to talk about. It's very important to brainwash all these issues, because it will bring a lot of problems, the problems we have never been dealing with in any past history.
Yeah, I fully agree with you, Martin, actually. But, you know, the answer, first of all, you know, Zuckerberg and his friends collect data about you. That did not stop you from using Facebook or Twitter or WhatsApp and everything else. We know they are doing that. So the need in the future will dictate your use. That is the problem. So it's coming whether we like it or not. Even coming. It is there actually now. But as physicians, as surgeons, we should jump into this and adopt it to contribute and fine tune it rather than just be the receiving end in it only. And at the end, I will tell you what I will suggest. Actually, I'm not giving just a lecture to tell you information. There will be suggestion at the end.
Okay, Dr.
Go
Munir, I
ahead.
have two questions from Dr. Swed Dogansi from Turkey.
Yes,
He's
sir.
asking Dr. Munir, congratulations. How come to combine these data with class score to increase its accuracy and with Wi-Fi score?
So actually, Wi-Fi score, it is just descriptive, not predictive. It has some predictive value, not a huge value. And we are writing a paper now about even pressure ulcers. To say Wi-Fi score just describe things that not predicted. But the artificial intelligence, if you get the Wi-Fi score from millions of people, put that score in a machine, then it becomes predictive. But it's still not at that stage yet. That's the difference. And that applies to any of those scores we are using. For Glasgow Coma Score is another one. We actually decided, somebody sat and decided based on the statistics, these are the important ones, but perhaps it was limitation of the human being at that time. If you put the device or the data in a machine, you might get a different Glasgow Coma scale, a different scale.
Okay, before we go to Dr. Samer, I think Dr. Martin wants to add something.
No, I don't really want to interrupt it anymore. I guess we can let Dr. Munir to finish his presentation because there
Just
is
have one question.
the whole evening we can discuss it basically, you know, over and over.
We can take Samir question. Yes, Samir.
Yeah, the main question, Munir, thank you for the presentation. It's great. If you look at our professional, we learn from our mistake. The reason why we are good now, we over all years with a lot of mistake, we learn from them. My question, can the machine learn from its mistake without human being interfere? Can they learn, can they improve themselves by themselves without human input?
As I said, actually, you have to have a human input. So for example, if some data is not important, somebody has to come and change it.
No,
But
I'll give, but I meant, Munir, like now self-driving cars, if they made a wrong turn and they have an accident, they can teach all other cars that there is a wrong turn, so nobody will do it in the future. That's what I meant.
yeah,
So can the machine do that?
The machines, but it has to be done by a human being. It has to go to a center for medicine because medicine is not a map. And I'm coming to that actually also some of the problem with these issues because all depends on the data and the interpreter. All depends. Medicine is different. For example, if you put 1 million data in a patient and then you forgot to say this patient has hypertension, for example. So your prediction is useless. So all depends what you put. Like in the car, I'll tell you what is one of the problem, a driverless car. When there's an accident in the driverless car because somebody decided 6 hours ago to put a partition like a detour. An accident happened. So whose mistake now? Is it the car?
No, but the car can tell the other cars not to do the same mistake, what I'm saying.
Yes,
They can do that.
It does that now. It does that in GPS. When you drive in California, for example, it tells you this road is all red, go another road to avoid problems. Yeah, it does that. But in medicine, I don't think we reached that stage yet other than give you information and you can override that information as a physician. You can.
Okay, you can continue, my dearest Munir, with this fascinating lecture, and then we'll take a few questions at the end.
So now robots. We've been talking about robots actually. A human, there's the difference between the humans and technology. I'm not going to go through that. There is the human touch in human intelligence. There is no emotional touch in the robot, but it works very well. And in vascular, Magellan is a very good example, but it is very expensive. That's the problem. It's about $2 million to have one Magellan to do angiograms for you. And I tried it. We did not buy it, but we tried it. Usually, human beings want more answers. In 2030, we need more answers on the patient and the implication of those answers. It is like a driverless car in a jam city. Can you really imagine to drive a driverless car in New Delhi or in Cairo or any of those? Nobody follows the rules. So this is the issue with machines. You have to have very well set rules to be safe. Driverless car is a very good example of it, the same as computers. Teams have to work together. There's an impact of failure. What happens? Whose mistake if there's a failure? If somebody dies from a decision, is it the one who programmed it? Is it the one who put the information in it? Is it the problem with the person who override that information? So these are issues not resolved yet. And I said that driverless car accident. For example, breast cancer diagnosis by mammogram, 72%, by machine learning, 65%, more than human, which is by 7% more. But who is accurate? Is it the human or the machine learning? You are comparing the breast image reading to whom? To the human reading. But once you get the data in it and you get a higher chance this is cancer, but the human says, no, it is not. So whom you are going to learn? This is a major decision. It is, for example, removing the breast now, perhaps, or doing a surgery. Is the patient going to believe the machine or to believe the human? These are the things that are really a lot we need to talk about. And this is what Samer was talking about. When the GPS, or driver's car depends on GPS, especially 5G down the road. So if there's an accident, whose mistake? It is the GPS who did not fill it, or it is the one who started it. There are a lot of obstacles in the research, of course. Data exchange. Can I exchange the data with another company? Does not provide incentive to sharing data at all. Even if you look, for example, in this hospital or other hospitals around me, 5, 6 places, they have different EMRs. They don't share data. Not only that, there are 3 hospitals have Cerner, which is one of the EMR, and each one of those is different than the other, and they don't share data. We are part of IntelliCure, which is a wound service EMR. They share data, but to get the shared data, I have to pay money. So these are all issues for the future. Do you trust the clinician or the machine? It's a black box. How can you trust it? Deep learning also can be deeper. So if 3 layers gave you better answer, why should I go with 3 layers? Why not 10 layers? But it needs a lot of work. Lack of interpretability. Sometimes you cannot. Technical problems in the machine, what will happen? Potential error also in the machine can be a problem. Are we going to be obsolete as surgeons? Most probably not. Although robotic surgery replaced a lot of the surgeons actually on the side of the patient, it did not replace the surgeon completely. This is again by Schwab. This is the part for a human profession, or the automation with the humans. Mental health, the chance to be replaced very low. Chief executive low. Sales managers low, because you need somebody to do the talking and talk to the human, convince, etc. Computer system analysis. These are the low. Psychologists. Imagine if you are talking to a machine as your psychiatrist. So these things will not happen. Physicians and surgeons are also low, but they are not very low, lower than others at least. The job automation is very important. Complex problem solving, it can work very well. A lot of data can work very well. The ethics is a problem. The ethics of data and privacy, the ethics of morality and algorithm, the ethics of values and practices. 20 years ago, if we told you there will be medical records that tells you what to do, you will say you are crazy. They are there. You know, whoever read the book about Google, I read it, is a very nice book. I suggest everybody should read it, How Google Works. So how Google works, they said we have to have two types of future plans. They call them moonshots and roof shots. Roof, the one on top of you. The roof shots solve all the problems around you as you go, but have a goal, which is moonshot, that everybody thinks you are crazy. It will never happen, like the driverless car. And they say the moonshot will happen. It takes 5 to 10 years if you keep working on it. The roof shots, if you keep working on it, it takes only a few days or weeks. So when they asked him, do we have all this data? What shall we do with it? He said, I don't know. The machine will figure it out. So exactly where we are now, machine will figure it out. We expect that the workflow will be done by a machine. It's already done by a machine. Actually, the workflow done by, I don't call patients now. Athena calls patients for me. We put the time for the patient to come. They receive a call 2 to 3 days or a week. You have an appointment with Dr. So-and-so. Don't forget the appointment, then another reminder. This is workflow automation. Triaging will be done also in the future by machines. Digital assistance will be also billing, clinical data collection, all by machines. A check follow-up will be machine. We call them, how are you doing? We want to make sure everything is good. Imaging, we said by machines. My prediction, we are not going to go anywhere unless something happens with the satellites. Medical assistance will be mostly machines. Integration of service will be machines. Registration, appointment will be all machines. Physician, surgeon will not be obsolete, but will be assisted by machines. And we don't know when. What about in vascular? So far, we can predict who will get peripheral arterial disease. We can predict amputation. We can predict management. We can predict which patient, based on genes, hypertension, smoking, will get an aneurysm. We can predict the progression of the aneurysm. So we can decide whom to fix, whom not to fix. Amputation prediction, I showed you. We're already there. Ulcer healing. We have actually another project we are going with for ulcer healing now. Stroke treatment is already proven. Endovascular intervention by Magellan is being done. You just write your line and sit on the chair. Even if the patient comes with certain factors like how long the lesion, how small the lesion, how much money he has, does he have insurance, and they put all together, will tell you, do that open, do that endo. Education, we are doing it now. The medical office nowadays is like this. It's not my office, by the way. And this is the future medical office. It's a machine, somebody running everybody for you, sitting somewhere. Education, we are not going to do ourselves any favor if we don't educate our students, our residents, ourselves, that the future of writing and reading the same as in computers, it will be machine learning for the future. We have to teach them all these things. So and artificial intelligence is a reality. Either we lead or obsolete. So this is my actually slide. My suggestions. I think we need to join to get data as much as possible one way or another. Education is a very good way of doing it. People who are interested to be part of machine learning, but they need to have a huge data with them, like if their hospitals want to join these machine learning issues, they can. A large number of teams, they should employ a statistician to help them do the machine learning. And the most important thing, really, don't say no when technology tells you, I can do this. Say yes, tell me how. Thank you very much. I'm sorry, that might be a little boring for you, but this is the future.
Thank you, Munir. It was very nice. And I want to tell you, now we have about 212 attendees following us, and this is nice. I have two quick questions from attendees. One from Hussein Abu Halub is asking a very nice question. Could artificial intelligence be used at wartime to predict the management of wounded patients?
We are already doing that.
Great.
We are already doing that, actually. I wish I can show you on the other computer, our IntelliCure system. It tells you what to do. It suggests things for you. It puts the guidelines, and then it flags. What about this?
We have a question, Professor Ma'moon al-Bashir.
Mamoon, I don't know him.
Good evening, good evening, everyone. This is what quarantined for 4 weeks does to you. So I'm just turning into a different person altogether.
This is against machine learning.
Is very nice, Munir, and I know you have great interest in this topic. You know that the most famous and the busiest doctor these days is Google himself. So
yes.
All our patients go on Google and they look up what they're going for. Isn't it dangerous to enable artificial learning with a direct consult with the patient? So if a patient goes into Google and he finds this, artificial program which tells him that if he puts his data in, what are the chances of him getting amputated? Well, two things happen. One, his consult to his consultant or physician is going to be suboptimal because he already has an answer in mind. And second, it might be dangerous in deterring the patients from the seeking the help they need. Isn't that a bit of danger in developing these programs?
So any technology has its ups and downs, dangers, and actually helps. For even the gun, you can protect yourself. The TV, you can use it for stupid things. The phone, you can really annoy people. But at the same time, it helps people to understand. I prefer they know they have the danger of losing their leg if they don't go to see a physician. So this is where you tell them, this is your chance. Let's see if we can improve that for you. Because if he comes to you or she comes to you and they end in amputation, they can blame you. Now they cannot. You have that chance from the beginning. So this is where it helps. So I am okay to open the door actually for people, their hospital to join Surgisphere. I'm going to ask Dr. Desai to give a lecture on this platform because we have 4 or 5 papers with him. He's a very nice person and you will benefit a lot. He is a PhD statistics. He left medicine and he just does 1 day a week surgery. The rest of it is does statistics and machine learning. So perhaps he will give a lecture on this platform at one stage.
Okay, I have another question from Biret Sharma from India. Excellent presentation. Your comment on the role of AI in the role of anticoagulation in cancer-associated thrombosis.
So if you take actually anything can be used. Once you have the data, like can this patient, what is the chance will get DVT, for example, then you go with anticoagulation. So anything, any question we have in mind related to medical therapy or prediction or complication, the machine will help you in it. Anything you have in mind.
Okay. I think
We'd like to take a question, Martin Marish. I think he has the question, and then we can take the first poll. Dr. Ayman, would that be okay?
Yeah, exactly.
You can open. Okay, you can open the mic to Martin Marish from Bahrain. Martin, you can open the mic from your end.
It's because it's the 1 hour is over, and I guess as Munir indicated already, this is too important topic. I guess we supposed to make just one evening, dedicated to data and the new technologies, because it's gonna be much bigger than. We are still on the surface of the whole issue, and Samir mentioned it. I like his way how he's pushing the human into it, but we won't be needed in the near future in many fields, and we cannot even imagine. The main problem is that we still think about the robots, but this machine learning process is much wider than, much broader than we are able even to imagine. This is, I will just tell you the last example just to have an idea about what is happening. I'm sure we are all old enough to remember these chess robots and the legendary, battles of Kasparov against the first computers. And he won something, then he lost, and then they improved the program and the robot, and then finally he lost basically all the battles. So they did the same with the machine learning. So they created the software which they learn only the move of the figures, nothing else. But it was the software which was able to learn from, because Samir mentioned the mistakes and errors. And it took 4 hours, guys, only. Before all these robots and improvement, the human improving the robots playing chess, it took a couple of years to got at the position that it was unbeatable by human. In self-learning machine, it took 4 hours from the very basic, just to move the basic stuff, 4 hours, and there was no other computer in the world able to defeat this machine. This is how it works. This is how it's going to be. This is the capability of the machines to learn from their own mistakes, and this will be the future. I guess we have to discuss it one evening only on this topic, because the one hour is already over, and I don't want to take any more time.
Excellent. I just want to give information that we have around 220 attendees so far, and we have another 200 watching us live on Facebook. So do you like Professor Ayman to put the first poll, and then we can move to Samer lecture?
Yes, please do it.
Okay, we're going to put the first poll. You can see the question is using the compression stocking for diabetic patient with leg edema. You have to select either A or B or C, the first line, second line, third line, and then we'll show the results. And you can press on submit, and then automatically the result of the poll will show to us. I apologize for the people who have given such a great question, but because we're short of time, and it was fascinating lecture by Munir. Congratulations, Munir. You are really sitting on the cutting edge. And thank you very much for sharing such a lecture with us. Can we see the result of the poll? And Samir is, oh, excellent. Okay. Here is the result of the poll. You have 83% on selection of C, which is possible with a specific material, specific compression. That's a very good message. So Professor Ayman is going to introduce the second presenter, our eminent Professor Samer.
Now, it's a great honor for me to present Samer. Professor Samer Kosayer is a consultant of vascular and endovascular surgery at the division of King Faisal Specialist Hospital and Research Center at Riyadh, Saudi Arabia, and associate professor of and teaching coordinator at King Faisal University. Dr. Samer got his training in general surgery in Weill Cornell University in New York, and continued his vascular training at the College of Medicine in Houston, Texas. Professor Samer, he's asked to be a specialist, and he will travel all over the world to give his speeches in Europe, States, and Africa. And it is very nice today to give us the opportunity to share his presentation about the anatomical difficulties in EVAR. I will leave the mic for Dr. Samer and enjoy it.
Can I say something quickly about Samer? Samer is a very dear friend of mine. and he's one of the most eminent vascular surgeons. He got his training in the United States. He used to plan for himself to be the second man after Hazim Safi for thoracic abdominal aneurysm. So he's exquisitely good surgeon. And with the new endovascular era, I was fascinated. He shifted gear to become one of the best open and endovascular surgeon I have ever seen. Sorry, I have to do this.
Thank you.
Samuel, please go ahead.
Thank you, Muhammad. You always impress me, you know. Can you hear me, guys?
Sure.
All right, let me figure out my screen.
Press on the green button at the end, share screen, and you open your PowerPoint presentation.
Can you see my presentation?
Fantastic colors.
Can you see? Let me see. Can you see my presentation now?
Yes, we can see it now. Please go ahead.
All right, guys, good evening. And it's very hard to talk now after Munir, you know. He brought us all to the future. I have to bring you back to reality, you know, like Back to the Future, if you remember this movie, you know. So we have to go back to reality now and what we have. First, I'd like to thank Professor Omar Farouk and Professor Ayman for this invitation, really opportunity for me to talk. What I'm going to talk today about really more practical point. I'm not going to talk too much about data because this is the whole idea from this meeting is that to learn from our experience. So I'm going to speak about how we deal with challenging anatomy in the EVAR. Oh, I can go forward. Here we are. I'm going to divide my lecture to 3 parts. First, I'm going to talk about the challenges we have it in the proximal landing zone, which is usually the neck. I'm going to give about 20 minutes because it's the most difficult part. Then I'm going to talk about how we overcome the problem with the contrarogate cannulation, about 10 minutes. And then this is the landing zone, about 5 minutes. And each time, give you like 10 minutes for questions. If you look at eye view, all of us, we know that the eye view, the diameter of the neck should be between 19 to 32. The length we need for the neck, if the angulation up to 60 degrees, we need at least 10 to 15 millimeter of the neck. If it's up to 75, then we need more than 15 millimeter. This is the eye view. And oversize should be between 15 to 20. Really, I'd like to go with a 20. I don't go with 15 anymore. I like always to oversize. I never have any problem with oversize. Always we have problem with downsizing. And it has to be free of thrombus and calcifications. But this is a reality world. This is what we see when we get the aneurysm. Very rarely that nowadays we see patients come to us within the eye view. So how we deal with that? This is a very nice paper written by Antonio, and he did meta-analysis of 7 major studies. And what he compares the outcome in hostile versus friendly neck anatomy. And what he found that if you do an EVAR for hostile neck anatomy, this will increase your type 1 endoleak about 4.5 and increase your aneurysm-related mortality about 9 times. Another paper by Spezial, he looked at the influence of multiple hostile neck parameter. And what did he find? That if you have 2 hostile neck, if you have 2 hostile neck, then interruptive endoleak go to 6.7%. If you have more than 2 hostile neck, then interruptive endoleak goes to 16%. So what he concluded that if you have more than 1 hostile neck parameter, this substantially will increase your mortality, morbidity, adverse event, interruptive endoleak, and adjuvant procedures. So let's start with the first part of the talk, which talk about proximal landing zone. What difficulty we can have? Most difficulty come from the neck. The neck could be short, could be tapered, could be thrombus, could be wide, angulated, or calcified. Let's start with the short neck first. If we have a short neck less than 10 millimeter, there is no place for regular EVAR. Then we have to go with a PVAR, FEVAR, chimney, helifix, or do an open repair. If the neck between 10 to 15 millimeter, then it's better to use an EVAR with cerebral renal fixation because it gives you a better fixation with this short neck. If the neck more than 15 millimeter, then you can use any EVAR available in the market. So what some tips if the neck is short, about 10 to 15 millimeters? Always start to deploy it above the renal. This is very important because always easier to pull the device down, push it up. Then don't deploy it more than 2 full stent because if you deploy more than 2 full stent, you cannot pull the device down. After that, wait until the stent up to the aortic wall and then put the delivery system down all the way down to the position which you want. Do an angiogram, confirm it, and then complete deployment. What if we have a short neck, less than 10 millimeter? Talk about juxtarenal aortic aneurysms. What option we have? The best option is to do a FEVAR or BVAR. But the other option, you can do a chimney, you can use an endo anchors, or you can just do an open repair. FEVAR usually or PVAR is our best options, best available options. The problem with this technology, it's a complex procedure. The maximum neck angulation can take is 45 degrees and has a large profile system, 23 French. So if patient has a small calcified iliac, could be a problem. It has a high renal reintervention rate. It's expensive, and it's custom made. Take a long time, especially in Saudi Arabia. It takes really couple months to get it. So it's not suitable for emergency or urgent cases. When we talk about SHEVAR, it is more available for emergency or urgent cases. It can accumulate more angulated neck with more challenging anatomy, and it's good for challenging access. If you have a small iliac, the device is much smaller than PVAR, and you can use it. And theoretically, it requires less spinal cord coverage, which could be really decrease the chance of paraplegia. To get a good result with a chimney, it's very important to have these two rules. You still have to have 2 millimeter minimum infrarenal neck length. What that means, you still have to have a neck between the renal and the aneurysm 2 millimeter. If you don't have this 2 millimeter, you cannot do the chimney. The second thing, the new neck should be at least 15 millimeters. You need to get a good healthy neck at least 15 millimeter. What does that mean? If you do one chimney to one renal only, then the new neck is measured from the lower level of the upper renal all the way to the neck of the aneurysm, and this should be 15 millimeters. If you decide to put two chimney, then the new healthy 15 millimeter should be measured from the lower level of the SMA all the way to the level of the neck of the aneurysm. So you need 15 millimeter of healthy aorta to get a good seal. If you decide to put 3 chimney, then 15 is not enough. Then you have to have a 2.5 centimeter healthy neck to get a good seal. If you do 4 chimney, usually it's not advisable. If you want to go 4 chimney, then better to do a BVAR or FEVAR. But if you decide to do it, it's better to do it a combination of chimney and periscope or chimney and sandwich technique. Oversizing is very important. Usually the rule is that we oversize 30%. Unless if you do one chimney, sometimes 25% is acceptable. If you want to be more specific, you can use with this formula. You can measure the aorta, the size of the aorta you're going to put a chimney in. Then you measure the size of the chimney, all of them. Then you divide everything by 2 and then get the size of the device you want. So this is a way you can do a calculation, or just go blindly with 30% oversizing. How we do the chimney? What steps we do it, especially for the fellow? First, we get an axis, femoral axis. This is for the EVAR. Then we get a left axial or brachial axis for the chimney. Then we go there, we cannulate the renal artery, especially with a Rosen wire. It's the best wire for the chimney. Then we put a long sheath all the way inside the target vessels, and then we put the cover stent. For the vascular access from the arm, it depends. If you use one chimney only, we prefer to go from left brachial artery. We use only one 9 centimeter 7 French sheath. If we decide to go with a 2 chimney, then we prefer to go from the axilla. We bought a 16 French short sheath, and inside the 16 French, we put 2 long 9 centimeter 7 French sheath. After that, we place the cover stent, which is a cover stent inside the target vessel. It has to be at least 2 centimeters inside the target vessel. It has to be at least 1 millimeter bigger than target vessel. Usually we need at least 5 centimeters of the length, and it has to end above the EVAR fabric. So this is the fabric that has to end above the fabric. So after we do that, we deploy the EVAR without deploying the cover stent yet. Then we balloon the EVAR again. Then finally we deploy the cover stent. This is the last step. But before that, don't forget, you need to withdraw the sheath, intruding sheath, before you deploy the cover stent. And finally, we can do a kissing balloon technique. If you decide to use a self-expandable stent, like a Viaband, it's always better or advisable to put a bare metal self-expandable stent inside it because the Viaban is very soft and can be compressed. The main problem with the chimney is the type 1 endoleak from the gutters. So how we can decrease that? Because this is the main criticism for the chimney. We can link the chimney graft, put a long chimney graft, as we said. We can long proximal sealing zone instead of 15. If we have a chance, we can go more if we can. So the longer sealing zone is better. We can do put a cover stent in a spiral position instead of angulation position to avoid gutter effects. And finally, we can do tracing or sandwich technique if we decide to go with the 3 or 4 chimneys. And second thing is, should we use balloon expandable or self-expandable stent? Which one is better? Which one has a less chance of type 1 endoleak? There's a lot of controversial issue, and I have no space to talk over that now. Give you a couple of our cases. Patient came to us with a 4 millimeter. You can see very short neck here, only 4 millimeter. So we are able to treat him with one stent here and one chimney to the left renal and then regular EVAR. And this is a result with a good sealing with no type endoleak. And this is 1 year follow-up without any type of endoleak. Another patient came to us again with a short neck. You can see here, it's very short neck, 4 millimeters here. Also, he have a narrow distal aorta. The neck is angulated. It's a conical neck. So we have a lot of anatomy challenging in these patients. So we end putting 2 chimney in the renals with an EVAR with a good result and no endoleak. So now what happens if you do a chimney and get type 1 endoleak? This is a bailout. You can do reballooning. First, just put Reliant balloon and reballoon your EVAR. Most of the time, you can get rid of the endoleak. Sometimes you can do a Palma stent. You can extend your proximal sealing zone by adding more chimney or by putting a fever cuff. Most of the time, really, if we have a concern, we put a coils in the gutters or we can put an onyx. Recently, we started using a Helifix anchor system around the chimney to close these gutters. And always open surgical repair as an option. But the most important to know that the majority of the type 1 endoleak from the gutters are benign and they disappear with the time. So don't get scared if you find it after you finish. If it's small and slow, you can leave it alone and majority of the time will go away when you do repeat CT or control CT angiogram in 3 or 6 months. What about endo anchors? Endo anchors, this is now is being available. It consisting of anchors. We have an applier here, and we have the guiding catheters. If you look at open repair, of all of us when we do repair, remember when we do an open repair, we do things. Open repair give us a longitudinal fixation and give us also a renal fixations. If you look at all EVAR, they give us only longitudinal fixation. There is no EVAR in the market give us a renal fixation. And this idea came to go and use endo anchors. Endo anchors, it resembles the suture line. It creates a fixation which is very similar to the suture line when you do a surgery. So it gives us 2 things. It gives us a longitudinal fixation and it gives us, like here, you can see how strong is that. This is a longitudinal fixation. And you can see it how strong. Also, it prevents us from separation if patient get a dilatation in the futures because it anchors the graft to the aorta. Because what happened in the future when the neck get dilated, the EVAR was separated from the aorta and get a type endoleak. So you put an endo anchor, it gives you a renal fixation and prevent that from happening.
Dr. Samer, may I ask you to give a chance for the ground and panelists to have some questions?
Now? Okay, no problems. We can stop. Go ahead.
Okay, I think Professor Tariq Abdelazim wants to talk. He has a question. Please, Professor Tariq.
Thank you, Ayman. Thank you, Samer, for the excellent presentation. But actually, no, my hand was risen for the previous presentation. I don't want to interrupt Samer now. Maybe we'll have some questions at the end. Thank you.
Okay.
Okay, I have a question to Samer.
Okay.
Oh, okay. Do you think the use of endo anchor to prevent the future endoleak type A1, do you think it will come as a common practice, or what is your opinion in that? When you have a difficult neck and you want to avoid having future endoleak type 1A.
So let me finish the endo anchors and presentation first, then we can answer.
Okay.
Muhammad,
Fine.
yeah.
There is a question by Martin. Martin have a question. We can open the mic for Martin.
What about, let me finish the neck first, then I can stop. What do you think, guys? Let me finish the neck anomaly first, then I'll give you 10 minutes to have a question. I think it'd be better than stopping the neck, because I'm still working on the neck. Yeah, because you may have some question about the neck. I'm going to talk about it, you know.
Okay. Fine. So you continue and then we'll stop for this section.
Okay, so we go about what the indication. Here's your question. What's the indication for endo anchor? We can use as prophylactic if you have a wide or short anatomy neck, or we can use a normal anatomy, but patient maybe we're going to listen for follow-up, so we want to give him a good repair from the beginning, or maybe he's a young guy, he has a long life to go, so we want to give him a good repair from the beginning. Or it can be a therapeutic if patient develop a type 1 endoleak, either early or late endoleak. It's being used with all kinds of devices. The only problem, contraindication, you cannot use it if you have more than 2 millimeter gap between the aorta and the graft. So if you have a thrombus more than 2 millimeter thickness, then you can use endo anchors. Or if you have a porcelain aorta, and of course cannot be used with EVAs. How many anchors we need to use? If the aorta is less than 28 millimeter, you need 4 anchors. We put our CM on LAO 30 to 45, we put 2 anchors. Then we switch it to RAO 30 to 45, we put 2 more anchors. But if the neck is more than 28, they need at least 6 anchors. Usually we put at this time we put an LAO 30, we move it RAO 30, then we go lateral 90, and each time we put 2. If we have an endoleak, then we try to put our endo anchors around the area of endoleak. We don't have to go all circumferential. We try to concentrate all our suture around the area of the endoleak. Give you some tips for when you do an endo anchors. First, you plan your case. When you do endo anchors, you still need a neck. You need at least 5 millimeter neck. If you don't have a neck, then you cannot use endo anchors, because endo anchors has to touch the aorta. It has to have a normal at least 5 millimeter of the neck. The second thing, you need to deploy your device very close to the lowest target vessels. You need to do ballooning first, and then you need to size the aptus. Usually we size it to the size of the endograft. But if you need to do an aptus in the outer aorta or in the fever, you need to do an undersizes to take the curve. Always place the cantilever at 90-degree angulation. Make sure you contact and penetrate the aortic wall. You need to anchor the proximal fabric very close to the edge. So you have to put your anchors very close to the edge of the fabric of the EVAR. And finally, if you can deploy, it's better to put 2 row if you can. And finally, try to space the endo anchor circumferentially so you get a good seal, not only in the area where you have a concern. The second thing, when you position the endo anchors, this is a wrong position. You should not see this circle here. It should look like an L shape. This is telling you are perpendicular to the wall, and you can penetrate the wall of the aorta. The second thing, you have to use the right size. If you have a small size like that, then when you push the endo anchors, they're going to push the device back. So you have no power to penetrate the wall. So you have to use the right size of the guiding catheter to get the penetrations. The second thing, if you work in the aortic arch, you need to use 2 guiding catheters. You use the right one, and then to get up, you cannot turn it up, it will never turn. So you need to use a smaller one to give you the turn up and put an endo anchors in the outer curve of the aortic arch. Give you a couple of our patients. This patient came to us with a nice neck, but because he's young and he has no endoleak, we decided to give him some endo anchors. This is as prophylactic. Another patient came with an angulated neck. Also, when we finished, was no endoleak, but again, because of the angulation, we put couple prophylactic endo anchors. This patient, when we deploy it, was low, and you can see significant endoleak here. So we have to put a cuff and put some endo anchors, and this is resolve the endoleak. Another patient, again, during the procedure, he developed an endoleak here, type 1 endoleak, was treated successfully with the endo anchors. Another patient, he came, I think, late with type 1 endoleak, even though the device in good positions here. So we treated with a couple of endo anchors with a good result, and this is follow-up ultrasound showed no endoleak. Another patient also, same good position, but type endoleak because it's here too far from the aorta. So we put there, put some coils, put an onyx, then put some endo anchors, and then this is a follow-up CT scan 1 year with a good result and no endoleak. So we finish with the short neck. I go now to the, let me finish with the neck and then give you time for question, go very quick. If you have a conical neck by definition increase the diameter of the aorta from up to down more than 4 millimeter. It increases your type 1 endoleak. The treatment to have a low threshold for placing a Palmer stent, and how we measure, how we size it. Should we go with this size, with this size? It's controversial. Usually I go with like an average size. I measure 15 millimeter from the neck and then see what the size here and oversize 20%. What if you have a thrombus? Most manufacturers tell you not to use an EVAR if you have a thrombus in the neck, but do we have any evidence? If you look at this paper from Portugal, they look at the influence of the neck thrombus on the clinical outcome. What they found that the presence of aneurysm neck thrombus has no significant influence on short-term or mid-term EVAR result. So thrombus in the neck should not be contraindication, and really it does not influence your seal, but you have to oversize. My tips, if you have a thrombus, you need to get everything in place. And then deploy the graft a little bit up and then pull it down, get it all right in once. You don't have too much manipulation because increase your embolization. Don't do ballooning. This is very important because you can embolize to the renal. And finally, decrease the wire and catheter manipulations. The last thing, the angulated neck. If you have an angulated neck, my solution is to oversize 20%. This is very important with the angulated neck. Adjust your C-arm to be perpendicular to the target vessels. You can do through and through neck if you cannot get through it. The through and through neck, you can get away from the femoral and breaker and femoral and breaker artery, and you can pull it and you can straighten up your neck. Or if you have an endoleak like this one from the angulation, you can treat it with a Palmer stent with a good result. Some tips, when I have an angulated neck, what I know before I deploy the EVAR, I remove the stiff wire because this will let the device to take the curve of the aorta because the stiff wire prevents that. And then I deployed it a bit high and then I pull it down and then finally I put the wire back. In experienced center, really angulated neck, it does not affect your outcome. I'll give you like last thing I'm going to talk, what happens if you deploy the device too high and cover the renal artery? What your bailout? This is what we need. The first thing, get your access from above, from breaker access and do an angiogram, see what's the problem. Second thing, you get the wire all over the flow divider and you have a wire coming from both femoral artery and then you pull the device down. But you have to be very careful because most of the device has an anchors now. So it can be ruptures aorta. So you can, I think, move it maybe a couple millimeters, not more than that. But you have to be very careful, don't rupture the aorta. And my advice, even if it looks like that, looks okay now, always better to put a renal stent because the device can coil up and cover the renal artery. So if you put a renal stent protruding inside the aorta, this prevents the stent from recoiling up and covering the renal artery again. The other thing, you can put 2 balloons in the iliac artery and you can pull the device gently down. But again, you have to be very gentle pulling down. I'll stop at this level and I'm ready for question.
Okay, thanks, Samer. I have 2 questions. Dr. Lueri asking about the use of cyanoacrylate.
As when?
He just mentioned if you use cyanoacrylate.
I never really used, I have no experience. I don't know if anybody else has any experience.
Okay, Dr. Ihab Ghazala asking about if a patient has contraindication for heparin, absolute contraindication for heparin or anticoagulation. Can you put him or schedule him for intervention?
I mean, they have to weigh the benefit and the risk in this situation, how important the EVAR to be done for him, you know, but doing EVAR without any heparin, I think is too risky. I think I will give at least a minimum dose, I think 3,000 or to 5,000. This is what recommendation. At least you need to give 3,000 to 5,000. But do it without heparin at all. I think it's risky and you may get to more complication.
Okay, I think there is a question from the panelist, from Martin Marish. He did raise his hand, so we can open the mic for Martin. Can you open the mic, Martin, from, yes.
Can hear you, Martin.
You need to press on open mic, Martin. Yes, we can hear you now.
How I appreciate Samir's lectures, because it's so well put and everything is there. The best way is to keep Samir very close to ourselves. Samir, I know you are master of chimneys. You really, I've seen it myself, and it's beautiful to see you working on these patients. There was just a question from the participants about the young patients having a difficult necks. So I just want to highlight that if there is a young low-risk patient, the open procedure is the way to go. Yeah, whatever magician you are with chimneys and with the endovascular techniques, if you have a young low-risk patient, it needs to go for the open procedures. This is just my answer to the participants. And my question to you, Samir, is about the chimney and the screws you use, or endo anchors. How you use the endo anchors in case of chimneys and endo leaks when the covered stent are actually keeping distance between the stent graft and the wall itself? How come it works when you have, the stent graft, the main body pushed away by the chimneys? How you configure the screws to be effective?
It's very good, two questions. Let me first start with the first questions. First, for young patient, even, if it's a good anatomy, always I think open repair is the best option. I still believe in that, The second thing, very important, guys, to understand my lectures. I will not advertise to go out of IFU. If you go out IFU, nobody will support you. You are on your own. All the devices being tested within the IFU. Anything out of IFU, it's just an experience. It just is out of the trials, So I will not advise anybody to go to IFU. If you have a challenging neck, the best way is open repair. For some reason, patient cannot go for open repair, then this is the tips and tricks. But I don't want anybody understand that we have to go out IFU. Because again, we don't know how this device work out IFU. This is only tips and tricks. It may work for a year, for 5 years, but we don't know after 10, 15 years because never been tested. When the company tests these devices, all tested within the IFU. So please, everyone stuck to IFU. If anything out of IFU, open repair is still on good options. I think all the tips and tricks, if patient cannot go for open repair and he has to have his aneurysm fixed. I go next to your second question is that what about the endo anchors? Very good questions. Yes, the endo anchors, usually you have this a triangle, right? So when you put an endo anchor, we try to put as far as possible where the aorta is not far from the neck. And slowly you can compress it and just pushing down, It may not make it completely disappear, but I think it decreases the size of endo anchor of the garters, and most of it will seal by itself. But the very important, be sure don't go through the cover stent itself. So usually if I do that, I put the balloon inside, the cover stent. Be sure that, because if the balloon rupture, I know I am through the cover stents, So just be careful, because sometimes the image is very difficult to see where you are. So this is my advice, put the balloon inside when you put endo anchors. Just be sure you're not going through and you're not closing your cover stent.
Okay. We have a question from one of the attendees, Dr. Mohammed Shaltut. If we can open the mic for Dr. Mohammed Shaltut to ask his question. Please introduce yourself, Dr. Mohammed, and ask your question. Mohammed Shaltut? Oh, yes, you can speak now.
Hello?
Yes, we can hear you, Dr. Mohammed. We can hear you.
Please go on, Dr. Mohammed.
There is a problem with his voice. We can take the other doctor, Dr. Yassine Ibrahim. Dr. Yassine Ibrahim. He have a question to Dr. Sami. We'll open the mic.
Dr. Samuel, thank you for this nice. Hello?
Dr. Muhammad, go
Hello?
on.
Yes, go on, Dr. Muhammad. Go on. Okay. Muhammad Shaltut, go on. Ask your question.
Hello, Dr. Samuel?
I'm Muhammad, تفضل.
Yeah. Okay. Dr. Samuel, for the chimney procedures, for chimney, for regular cases, if there is leakage, how many at least to introduce to get the best result to treat this leakage? How many endo anchor regularly you are using?
If I understand your question correct, you said if you put a chimney and then you get a type 1 endo leak and you want to use an endo anchor, correct?
Yeah, yes.
How many you put?
How many? Yeah.
I mean, you have up to 10 in the system. Usually, I put 2 or 3 on the both side of the chimney, and then I put I put at least 4 or 5 around the graft. I still put a couple of them around the neck, but I try to concentrate around the area of the type 1 endo leak, the gutters area. So I put 2 at least on each side.
What is important to highlight is that Samir mentioned that the delicate 1A endo leak in chimneys procedure you can just leave alone. It's very benign condition. You can just follow these patients closely and you can intervene later if needed. But in many of these cases, there is no need for secondary procedures.
This is correct. This is correct.
Yeah. If any of the panelists have a question, he can just raise his hand and then we can open the mic. If Professor Ma'moun al-Bashir or Tariq Abdul Azim.
Question or a comment?
Question or comment, yes. Or Professor, yes?
Hello, I have a question if I may, Dr. Samer.
Yes, please, Dr. Ma'moun, go ahead.
Samer, given all available options with a short neck, which one would be your primary option? So if you have a case where there is a short neck and one of these, the cramps, the fevers, the chimneys, what would be your main option, the one you would go for first?
If patient is a good candidate for surgery, I still think that surgery is the best way to go. If patient is high risk for surgery, I think the PVAR is the best option. But again, the problem here in Saudi takes a very long time. So if you have an access for the PVAR, I think this is the best option. My third option will be the chimneys.
Excellent. Professor Tariq Abdul Azim, your mic is open if you want to have any question.
Well, just a comment really. And again, I'd like to thank Samuel for an excellent presentation. But I basically just want to emphasize what he mentioned, is that I don't want the junior staff to think that everybody is a candidate for EVAR, even though we have all these nice tools to prevent endoleak. But you always have to remember these are quite complicated techniques, quite difficult, quite expensive. And again, I agree with him completely that if you have a young patient who is fit for surgery, then open surgery is probably the better way to go for somebody with a hostile neck, especially if you have 2 or 3 parameters for a hostile neck, not just one. Thank you.
Excellent. That's an excellent comment.
A question from Zayed Al-Ubaid. Dr. Zayed, please.
Okay, we'll open the mic for Dr. Zayed. Please
Good evening,
ahead.
sir. Good evening, sir. I'm Dr. Zayed. I'm from Iraq. I'm vascular surgeon. It's a nice presentation from you, Dr. Samir, as usual. I have a question about type 3 endoleak. I have a case. I face a case of type 3 endoleak. I don't know how it's happened, maybe due to ballooning or something, but there is a primary type 3 endoleak. My question, what option you have for type 3 endoleak?
Type 3 endoleak, you have to put an extension. I mean, that means you have this location,
The location was in the flow diverter, sorry. The location at the flow diverter. For the first, we thought that the tear at the iliac limb, so we put a graft, but actually it's at the flow diverter, so not covered by.
So it's type 1B. It's type 3 or type 1B?
No, type 3. It's maybe due to tear in the graft itself.
So it's type 4.
The flow. Yeah. No, type 3.
Because type 3 is dislocation of the component. You know, so we have to be agree. See, type 1 from the landing zone. Type 2, you know, the lumbar. Type 3 is a component. Type 4 is a fabric, and type 5, you know, the endotension.
I mean, sorry, yes, type 4 from the fabric itself, yes.
So from the fabric.
Yes.
I think it depends how soon you see it. If you you see it during the procedure, you can leave it because most of the time we'll see it because patient's still on heparin, so this will go away by itself. I will just watch it, you know. There'll be a CAT scan about 2 or 3 months. I will see. If the aneurysm, I think I treat like type 2. If the aneurysm sac is not enlarging, I can just watch it. But if I see any signs of sac enlargement, and I'm sure it's type 4, you can realignment with a new EVAR.
Thank you.
Excellent. So we can go ahead with the second very interesting part of Dr. Samer. Yes, please go ahead.
Second part, I'm going to speak about contralateral gate cannulation, because this is the most difficult part of the procedure. It could be a time consuming. Sometimes it takes like half an hour, sometimes it takes an hour. I think this is the most difficult part. It increases radiation exposure. Could be difficult, especially if you have a large aneurysm with a little thrombus, or the opposite, you have a lot of thrombus inside the aorta with very narrow residual lumen. If you have a narrow aortic bifurcation, or if you have a severe aortoiliac angulations. So I'm going to give you like 10 tips. You know, I'm going to go through that. It's just tips how we can make the cannulation much easier. You know, let's say we have this kind of patient who has a large aneurysms, you know, very little thrombus and a big aneurysmal sac. So if you go and put your EVAR as a C shape, like from the left side, what happened? Your contralateral gate will be inside the big sac. Then it'll be very difficult for you to go over and cannulate it. So it's make it more difficult. Where if the same anatomy, I go and deploy it from the right side, like an S shape, like this way, then the contralateral gate will be trapped between the ipsilateral limb and the aorta. So you have a narrow space, so it then become much easier for you to go and cannulate. So in this way, it's better to put it in this S shape than in C shape. Let's say tip number 2. If you have an angulated neck like that, if you go and put it again from the left side, like in a C shape, what happened? The contralateral limb will be protruding upward, and sometimes it will be inside the thrombus. Then become very difficult to go and cannulate it. Well, if we go from the right side in an S shape configuration, then the limb will be straightforward, and then will be a straightforward cannulations. Let's go tip number 3. If you have a larger thrombus and very narrow aorta, then and you go and deploy your devices like that completely, then you have end with a very small lumen to cannulate. So in this situation, it's better to just deploy the contralateral gate and then stop. So the ipsilateral will be collapsed. So you have more space here to go and then become much easier cannulations. Tip number 4, you have to have a selection of the catheters. You cannot depend only on one catheters. The most common we use is a vertebra or Bernstein, but it's better to have different type of catheters. Sometimes multi-purpose, Jotkin right, Cobra. We use a lot Amplatz left 1 and 2, and Amplatz right, also you can use it. So it's better to have multiple sections of the catheter for cannulations. Or if you have money, you can buy the Destino steerable catheter, but I don't think you need it. Give an example, like this patient, same way you talk about it. If you deploy it in this way, this is very easy. You can use vertebral catheter and you can go there and you can cannulate it. But if you deploy it in the C shape, then the vertebra will never able to get cannulate the neck. You can spend like an hour there. Then you have to use a Jotkin or Cobra catheters with the angulated wire, then you can get a cannulations. Or you can use the Amplatz right or left, and then you can get the configuration, and then you can get cannulation much easier. So selecting the right catheters make it much easier for you to cannulate the contralateral gate. Tip number 5, if you have a tortuous iliac artery like that, it becomes very difficult because tortuosity becomes very difficult to control the catheter and wire. So in this situation, it's better to go and put a long sheath. We put a long sheath in the iliac then become straight. You straight the catheters and you straight the iliac, then become much easier to cannulate the contralateral gate. And second thing, I sometimes use long sheaths to change the configuration of the catheters. Like if you see like catheter in this shape, I want it to go up more. I just pull the catheter within the long sheath, and the more you pull it up, the tip of the catheter will change and give you different angulation for cannulation the contralateral gate. Tip number 6, it's very important to have multiple C-arm view when you do your cannulations. Because remember, you're working in 3D view where the C-arm give you only 2D view. Like, so usually what we do, we put the patient on RAO 45, and I put my catheter wire in the location which I think is the right. Then I twist the C-arm LAO 45. Then I go 45 left. And then I can see my catheter is too far. Then I push it back to the way it's supposed to be. Then I go back RAO 45, and most of the time you just go straight to the contralateral gate. The other technique, you can what we call the orthogonalization methods. What they advise that you rotate your tip catheters until the catheter project as straight line. This is a vertebral catheter, so you keep it twisted until it become like a straight line with the contralateral gate, like become straight line if it's curved. After that, you twist your C-arm about 90 degrees, and then you twist your C-arm until sees the highest curve of the catheters. At this time, then that means your catheters and the contralateral gate in the same level. Then you just push the wire and the wire will go through it. Tip number 7, should you do conventional or ballerina deployment? Should you deploy this way or this way? It depends on the wire when you put it in. I'll give you like if patient this one and both wire looks parallel to each other's, like this way, when they go through the aortic bifurcation, then it's better to deploy it in the conventional way. Because if they deployed it in the ballerina deployment, like if you deployed it in the ballerina positions, you see your catheter is here and your contralateral gate here. So it becomes very difficult. So the situation, just deploy it in normal deployment, and it become very easy to deploy and become very easy cannulations. And you can see it here. Let's say, but if the wire cross each other in this way, like we see it sometimes if you have an iliac tortuosity, then if you deployed it in the regular way like that, then what happened, contralateral gate is too far from your cannulation catheters. Then in this situation, it's better to deploy it in ballerina positions, then the cannulation become much easier and you can cannulate the gate very easy and you get these configurations. Tip number 8, always you have to be sure you're inside the main body. Usually we use a big tail or we use a balloon and we twist it inside. The other option, you can hook the big tail at the flow divider and you push it down. If it's straightened up, that means you are inside the catheters. The main problem with this two technique is that you have to take the wire out. And this is because sometimes could be risky if the big tail pulled out. So sometimes I use what we call a mushroom sign. So you keep your wire there and you put your reliant balloon. You part of the reliant balloon will inside the gate and the other one inside the main body. And inflate the balloon gently. If it's take this mushroom shape, that means you are inside the device. Or the other way, you can put it partially inside the gate and partially inside the sac. And if it's took this mushroom sign, that means you are inside the contralateral gate. The good thing about this balloon is that you still have your wire. You don't have to take your wire out. So it become more secure. Number 9, let's say you try all the technique and still you cannot get through the gate. Then it's the easy way. Just go from the arm, go up through the contralateral gate, then or go from the ipsilateral gate limb, go over, push the wire down, go from below, get a snare the wire, flip it over, and you're done with that. Last step is number 10. What you have if you jam the contralateral gate, or if you deploy too low where the gate is inside the common iliac artery, or it is kinked. One solution is to open contralateral gate by contralateral balloon, aortic balloon. You can push it, or you can attempt to go up and over and then snare the wire and then try to push it and open it up and finish the deployment, or you can convert it to aortoiliac configuration if you have to. Like this one here, you can see the gate where it's stuck up. So you just go up over and you go with the wire through it. You go from below, you snare the wire, flip it over, and then you can open the gate and you can finish your deployment. Last thing I'm going to speak about what happens if you have a mal-deployment, how you get yourself out of trouble. This is the last one. If you have a bimolar EVA, like a Gore or Medtronic, the things you need to go through here, but you can go in the wrong way, like behind the congenital limb without knowing, and you end up deploying the limb outside the main body. And this solution is very simple. You just put the wire back from above, and you push it, and you put a new limb, and you push this one outside. Or if you use a trimodular EVA, like from Cordis or Cook, then you can go the right way, you can go the wrong way, like here, but you can go the very long way. You can go through the ipsilateral. This is very important to know that this could happen. Like this patient, he came to us, is a regular patient. I mean, nice EVA, nice neck, you know. You can see it here, very nice neck. We thought it would be very simple case, you know. We go there, this is EVA. So our wire, instead of going this way, it went the wrong way. It went in the ipsilateral because we're using the trimodular device. So what happened, both wire went through the ipsilateral and the both limb deployed it inside the ipsilateral limb. So what you do now, you have a gate is open, you have a major endoleak, there's no flow to the left limb. So what options? We have 5 options to deal with this problem. This is the case here. You can see both limb here stuck and this one still open here with major endoleak. One option you can convert to open, always open, it's not a big deal. You can, if you are a surgeon. Second option, you can convert it to aortoiliac and then do fem bypass. This is another option. The third option, you can go from above, put a block, close this contractile limb, so you stop this endoleak and do just fem bypass. Fourth option, you go from above, push the wire down, then snare it from below, and then flip it over and put a new limb. The last option, what we did really, we went down because we don't want to go from above. We went between the fabric and the iliac artery with a glide cut and glide wire. We put all the wire inside the sac. Then we went from the contralateral gate. We put our wire through down. Then we snare the wire. We flip it over. And then we put balloon expandable stent. We don't put a limb because we felt the limb would be soft. So we put a balloon expandable stent all the way down. And this during the procedure, you can, this is the limb, and this completion angiogram was a good result. And this is flow to both limb. And this is follow-up CAT scan, I think in about 6 months or a year. You can see complete exclusion, no endoleak, and both limb are open. And you can see here both limb open, and this is the old limb which being mal-deployed here, is compressed. And this is follow-up CAT scan after, I think, 1 year, with no endoleak and both limb are patent. So I'll stop here before I go to my final part of the presentation. I'm ready for any question about contralateral or contragate deployment.
Yes, there was a question from Professor Mahmoud Salah, or a comment. You can open the voice, all the panelists can open the voice from their side. So Professor Mahmoud Salah, and then we'll continue the third part because we are very near to the very interesting lecture by Victor Kanata. Professor Mahmoud, you can speak.
Samer, as usual, fascinating talk. And you covered most of the tips and tricks, the practical points that we sometimes face. I have one question. If you have a patient with type 2 endoleak, one of the lumbars is leaking, and something very mild that you decided that you will follow up, but after 3 months, 6 months, the size of the aneurysm is not getting any smaller, but it's not getting any bigger. It is the same, okay? And the patient is not complaining of anything. I know what the book said, that after 6 months, if it's not getting smaller, you should interfere. But I mean, if the patient is not complaining of anything and it's not getting any bigger, would you recommend to follow up, or you have to interfere? And if you are going to interfere, what you will do?
All right, very good question, Mahmoud. I think as far as the size of the aneurysm is stable, I do not interfere. I can still wait. But I just have one concern. Many times we can miss type 1A endoleak, you know. We think it's a type 2. So I think it's better, very important to study your imaging very well and be sure you are dealing only with type 2 endoleak. because again, sometimes you can have a combination of type 1A endoleak, like small one, or dynamic type 1 endoleak, you know, with type 2 and with the type 2. So the first thing I will do, maybe contrast enhanced ultrasound to look at the dynamic and be sure I'm not missing any type 1 endoleak. If I'm sure it's only type 2 endoleak and the aneurysm sac is not enlarging, I think most people agree, just keep watching them. But if it start increasing, then there are problems. If you have to treat it, I mean, it depends a lot of technique, but I found the easier technique, which I did it in the procedure when you have a problem. Just got your vertebra and vertebra cutter and glide wire between the iliac limb and the common iliac artery. And always, even if patient has an EVAR for years, always you can get an access behind the graft and give you a straight shot to the sac. And from there, you can do whatever you want. You can put a coil, put an onyx, whatever. But I found this is the easy way to get to the sac by passing between the iliac limb and the common iliac artery. I know if the panel, maybe the panel have different opinion because we have a lot of expertise here in this field. So maybe it's nice to hear their opinion also.
Okay. We have another comment and question.
I have a question. Please.
Yes, please go ahead. Yes, please.
Okay. No, what is?
Yes, go ahead.
Okay, I have a question to Dr. Summer.
Yes.
Go.
Do you use the antiplatelet drugs before, after single drugs or double drugs?
I think the question, if I understood right, is do I use any antiplatelets after the EVAR?
Yes, antiplatelet, yes.
Yeah,
yes.
No, I don't use it. Really, I like to be stopped because if I have any type endoleak, I want this one to stop. So if you use an antiplatelets, then this may prevent the type 2 endoleak from stopping. So I prefer not to use any. The only time I use antiplatelets if I have to put like a chimney, or I have to stent like iliac and if I put some like stent other than the EVAR. But if it's just straightforward EVAR, I don't use any anticoagulant. I mean, I don't use any antiplatelets.
Okay.
Before and after.
Yeah,
before and after.
Okay,
thank you. There's no reason, yeah.
Okay. Professor Victor, yes, go ahead.
Samir, there is a great question from participants. Do you use IVUS? Do you see any benefit of IVUS in these cases?
Not really. Not really. Maybe it's only if you have a dissection, but in the straightforward EVAR, the only time, sorry, yes, I use it only if I don't have to give a contrast. We have a couple cases like that. If patient has a renal insufficiency and I don't want to give any contrast, then yes, you can do even the whole deployment through with the IVUS. And we have, I think, 2 cases like that. So only if I cannot give a contrast for some reason. But now you can use CO2. But for a reason you cannot see CO2, you don't have it, and you cannot use a contrast, I think IVUS will be very, very helpful. And you can get very accurate, really, deployment. It's an excellent, really.
Victor Kanata have a question or comment, please, Victor.
Very nice presentation, Dr. Summer. My question is just, what is actually your success rate? And there is any difference between like, I'm living in a country with low amount of cases, and also we do just not too much of those cases. Do you have a difference between centers where they doing very frequently and very often, and centers that they're just doing like occasionally to see the success rate?
Yes, it makes a huge difference, really. I mean, because again, I mean, most of the time you don't get a good success from chimney or any other angulated neck if you don't do it in the right way. So do it in the center with a high volume, it makes a difference, you know. The second thing I think is a nice study. They look at the complication of any surgery in regular center and high volume center. And they found really surprisingly that the complications are the same. The difference is the outcome, because the high volume center, if you get complications, you know how to deal with it and you get yourself out, so you can get less complications. But the complication always happen in every place. But I think the differentiate the high volume center from other centers, that if something happened, I think they have more experience to deal with the problem than other centers.
Okay. If we can go quickly to the third part.
Yeah, third part will be quick and simple.
Quick,
I mean,
okay.
it's very quick. I don't take anybody time. Very quick. If you have a distal landing zone, if you have narrow aorta, what we can do. I know it's not working. Here we are. Narrow aorta by division less than 20 millimeter can cause limb occlusion if you put a bifurcated graft. The solution after you put an EVAR, you can crack the calcification or the narrowing by doing high pressure balloon, but this is after you put an EVAR, don't do it before. And sometimes you put a cover stent inside the, or not cover stent, uncover stent inside the limb to keep the bifurcation wide open and prevent compression of the limbs. The other things you can convert to the aortoiliac and just do fem-fem bypass. The other solution, if you have an access to endologic, you can use it because endologic, it sits at the bifurcation, so you have no limb compression or kinking. Recently, really, we have a Cordis, the Incraft system, which is very low profile system, and are surprisingly to see it even fit in the distal aorta down to 11 millimeters. So it is very nice device. If you have a narrow aorta, I think this is might be my best option if I have a narrow distal aorta. If you have a common iliac aneurysm, you can coil and cover it. I don't think we do it anymore because a lot of studies showed that even occlusion 1 iliac can cause problems. You can bell button technique. The long term, we don't know. The iliac branch is the way to go, I think. But the problem is the iliac branch, 35% of the patient, they cannot fit because if they have a special needs, special anatomy to do an bifurcated iliac stent. The other way you can do a sandwich technique is very simple. After you put an EVAR, you go from above, you cannulate the internal iliac artery, and then you put a limb in the iliac and you put a cover stent in the internal iliac, and then you deploy them both like in a sandwich technique, and you can get a good result. This is good if you don't have access to the bifurcated IBD, but if you have access to IBD, I think IBD will work better, but this is a solution which can really help if an emergency cases or you have no access or so expensive. Access vessel is very important, could be narrow, especially iliac artery, you could be calcified. If any narrowing, try to dilate before you put it there. If the whole iliac is narrow, don't dilate it, then use a conduit. We didn't use conduit for a long time because especially now the device getting less and less smaller in profile. If you have tortuous iliac artery, you can use a Lander Quest, or you can put some pressure, or you can use a body wire technique. The only problem I want to mention here, if you get what we call the iliac on a stick, if this happen, don't get panic, guys. If this happened, if the iliac came out, just put a pressure on your hand on the abdomen. From the other side, go there and put an occlusion balloon here, so you stop the bleeding, and then assess yourself and put a cover stent. Most of the time, you'll be successful. If it's not, then just do small incision and convert to the open. So in conclusion, on my lecture, recently we see a lot of patients came to us with EVA with abnormal anatomy. Usually, always we can get away. I still think, again, open repair is the first option, but if it's not, there's a lot of tools to get you away with this anatomy. But always remember, if you have more than unfavorable anatomy, you have to watch out. If you have one, like if you have a narrow neck, short neck with angulation is too bad, you know. So I think one unfavorable anatomy is acceptable. If you have more than one unfavorable anatomy, I think you have to watch out and look for other options. And always remember, we are a vascular surgeon, and always open repair is an option. Thank you very much, guys.
It was excellent. So fascinating. So we'll take the second poll now to shift to the fascinating next lecture by Victor Kanata to share us his experience. So here is the second poll. I will read it. The best solution for the fast healing in case of venous ulcer to apply compression with. Option 1, compression garment kit. Option 2, short stretch bandages. Option 3, long and short stretch bandage. So we have 1 minute to give an answer. You select the option and do submit. And I will let the Professor Ayman do the nice introduction to Victor Kanata. By that time, we'll get the result of the poll, and then he can start the lecture. So if Professor Ayman like to introduce.
Nice. We have to save some time.
Yes.
Okay, it was a very fascinating lecture. Thank you, Samer. I think we all enjoyed it. And I'm expecting Professor Kanata will give us a very strong and nice presentation. Professor Victor Kanata, he is a professor at Clínica Corriga from Paraguay. He is the president of the Society of Phlebology and Lymphology of Paraguay and vice president of International Union of Phlebology. He's a professor of surgery in University of Asunción in Paraguay, and he is also a professor of anatomy in the same university. That's give him a very good chance to do everything correctly. Professor Kanata is a very nice and good friend of me and visit us in Alexandria 3 years ago, and did a very nice work with us in sclerotherapy and vein ablation. Now it's very nice to speak about the very interesting talk about the claques in C1 patient. I will leave the mic for Omar to open and declare the result of the poll, and then we'll enjoy the talk with Professor Kanata.
Yes, you have seen the result of the poll. It was shown on the screen. 51% selected garment, which is strange, really. I'm sure there is a lot of knowledge we need to grasp about using garment. But anyway, we are all are very excited about the new lecture with all the nice tips and tricks of using laser, get a fantastic results. We have now more than 500 doctors all over the world, all open eyes and ears to Victor Kanata. So please, Victor, go ahead.
Okay, let me share my screen. Give me a minute.
Yes, yes, we can see your nice color in the screen. And we can see the television behind you as well.
This is just, I would like to just remind that I'm very happy to have so many friends. Now we are already more than 220 people in the meeting, and meaning that everybody wants to know what's going on and what is the way that we are working right now in aesthetic phlebology and all the ways in vascular surgery too. My previous presentation, the two ones, was very nice, and I will just remind that I'm very happy because just after the COVID, I was trying to just get some kind of work, and I'm doing delivery. But right now, since Ayman give me some job, I'm able just to get something. I'm proud to have Ayman as a friend because I dropped my delivery shot, and right now I'm doing the lecture because everything stopped after the COVID. Okay, fine. The final idea of the clocks is trying to improve the way that we are working and trying to just have a new wave of working that is trying to improve the way that the patient are coming after the laser and the sclerotherapy. And the clocks are already was designed by Dr. Katsuo Miyake in Brazil, and he's mastering with very nice courses yearly all over the world. There are people already that they are developing the techniques right now all over the world. I will try to show the way that it's working. The acronyms of the first one, just to remember, I don't have a conflict of interest. There is nobody else who just can interfere in whatever I'm saying. It's a new revolution in the vein treatment, and I think from my point of view will change everything that we are doing for so many years. Is the acronym of cryolaser and cryosclerotherapy, and together show us the new path for this kind of new treatment. The laser treatment is done under the frozen earth, which help the patient with the pain as well as improving the effect of the laser beam. Then the sclerotherapy with glucose 75 and no compression is applied. The whole treatment is done in one session and the patients are very happy with it. How we choose and how we do the stuff? We do in that way. We use 50% glucose as a sclerotherapy agent or 75, the ND-JAK laser 1064, a vein viewer, and a frozen machine. And that is something new that we have to remember as a vascular surgeon and as a phlebologist. And this is something that we have to change. To remember that we have technical requirements. The technical requirement for it is the Flevo suite. The Flevo suite has to be changed. The old Flevo suite is just an old one that we have to forget about it, and we have to invest in the machine. We have to invest in new treatments. We have to invest in trying to have the new tools for have a better results in our daily practice. Second one, you must have an augmented reality or a vein viewer. You must require a laser ND-JAK 1064 and a Fredo frozen machine and also the sclero agent. Long time ago, you remember that picture? This is the picture that we have for so many years. The old Flevo suite with a tool from the physician who is doing the sclerotherapy, the escalator that usually go 1 or 2 steps ahead, the light at the side, the improvised maybe tied by a wire of a new light. This is an old Flevo suite. That kind of old Flevo suite has to be forgiven. We have to get the new way of the treatment has to have like this. You will see the new Flevo suite has to have everything, and the investment of the phlebologist, the vascular surgeon, or the agency who will take care of your practice has to be like this. You see on one side, you will see over here the laser, you have very nice light, the floor is very good, clean, and well fitted for like a treated the patient without trouble. You might see also there is a machine of anesthesia. If you are in trouble, when you do your treatment, you will be able to assist the patient. Also, you will have here the sonogram machine, meaning that the new Flevo switch is changing everything. And you must have this in your clinic to improve yourself and to have better results. What are the final idea when you have to do all the stuff? You must understand the Venous disease. You must know anatomy. As I say, I'm a teaching professor of anatomy on my university. You must know about physiology. Pathophysiology, you have to learn about your diagnostic tools. You have to have a very careful history and physical of your patient. And you must learn and do the duplex ultrasound. Everything is also part of whatever you are doing to improve everything and have a different view and an aesthetic view of the treatment that the patient will require and will ask for us. The patient right now is not like the old ones that they just feel that whatever we are doing to them will fit for them without trouble. Now they are aware of the internet, they are aware of the treatment, they know everything, and they ask us for results and everything. The first part of that trouble is that photo documentation. Photo documentation is the key for our trouble. And when you have an aesthetic patient, you must explain him that the patient has to show everything, and you must take a lot of pictures. There are very nice machines. There is so many ways that you might able to just put that in a computer to have everything. In my office right here, I have four large TVs, more than 50 inches TV to show the improvement to the patient after the first, after the second, and after the third session. Also, you must improve in the way that you put the numbers and in the way you are tapering the
skin of the patient. This was one of the nurses who put over the skin of the patient a number, and then the patient get upset. If we was in trouble, the skin was not clear after we cleaned it up, and we were in trouble. You have to just realize that after the photo documentation, this is more than 80% of your task when you have those patients. You may see over here, there is a large collateral. There are veins that are draining over there. Over here, you can see 2 or 3 small spider veins. And in the right one, you will see when we put right side, we put a number, we put a series, and that kind of series, you will be able to have that kind of trouble, and you will be able to just fix the patient and try to improve everything. The other tool that you will require is the vein viewer. The vein viewer is a new machine who is just working and is giving us different view that we have from so many years ago. The vein viewer superimposes the data or the image directly onto real objects or environments. It connects the physical world to the digital world, making it easier for the people to learn information, make decisions, execute the task more quickly and efficiently. The vein viewer system will be able to work in and improve our practice, and the patient likes it so much. It works by increasing the contrast of the veins by digital imaging a continuous spot over the skin using an infrared camera, enhancing the acquired image by a software, and then project the image in green over the same spot. This is the way that you, after the vein viewer, you will see everything. There is a patient, you don't see anything, and after the vein viewer, you see the feeder veins, you will see some small spider veins, and if you just increase a little bit higher, you will be able to see the capillaries, and you will be able to see the veins, you will be able to see small arteries shining over there, and giving to you the idea of what's going on already, and where is the area that the patient is in trouble, just to fix it with the clocks. Now, the final slide for that first point is photo documentation is mandatory in clocks and in all the phlebology aesthetic patients. This is one excellent point from my view. I just want to stop. I would like to have right now, from now on, the comments of the people. I have so many colleagues from all over the world who are doing the procedure, and I would like to know what are their recommendations and the way that they are working from now on. Omar, can you just...
Yeah, great. Thank you, Victor. Very nice talk, really. And as you said, we have a lot of phlebologists all over the world. We have Dr. Eugenie and Dr. Ashish from India, and we have those number of Brazilian fellows, Alvaro, Felipe, Luis. Let us start by Eugenie. Have a comment, Dr. Eugenie? Have a comment? Please, you can open your mic.
Yeah, thank you. My comments for the Victor. What is the diameter useful for this technique? Amazing. What do you think? What is the diameter of feeder vein or small vein we can use this technique on the patient?
Okay, usually my experience showed me that until 2 or 3 millimeters veins, I'm able to do it. But I've been working just a little bit larger with very good results with no trouble. But I would like to know what Dr. Ashish said regarding about that. What is your diameter and how did you start working with those patients, Dr. Ashish?
Okay, Dr. Ashish from India, please.
First of all, greetings from India to everyone. We started off very well on the talk. As far as the answer to the diameter thing is concerned, I think what is ideally recommended, the recently published white paper report, the CLACS technique in the phlebology, is 0.1 to 1.5 millimeter veins can be treated. Though personally, I do treat veins even up to 3 millimeters, and I have had no problem to date.
What do you think, Philippe?
I think the diameter is a good point of discussion. We've been using CLACS technique with very high rate of success in veins up to 4 millimeters. But the point is, we use a compression when you use in such veins. We've been using thigh-high class 2 stockings with a cotton roll eccentric compression. And it's been shown that it improves a lot of the results when you treat larger veins.
I have just a question for Eugene. Eugene, how do you work with the photo documentation and how you store it? This is some key of that trouble that we have, because I have in my office so many patients who just came. I take the pictures, and then after this I do the treatment, and when they coming back they say, I don't see the results. When you show the difference, everything changed and everything is clear. What do you think about Jim?
I need to say the first that I was certified at the Clinica Miyake from the inventor of this technique, from Kazuo Miyake, professor. And I finished this course at his clinics and all of the parts of this technique. And one of this is crucial for the documentation. It's a special camera, a special settings on this camera, a special some kind of pose, and everything what need you do from one patient to another patient. You need to keep these photos in your some kind of archive. And when the patient do the procedure, he can't the possibility to remember his legs. And you, it's like a doctor, also have no possibility to remember every patient's what was the picture before and after procedure. And for documentation, it's crucial for this analysis and for these outcomes. You can search the patient's file and see what is before and what is after the procedure, and you can show for the patient, look at this. This is your legs. Yes, this is my legs. This is one legs we did the clocks. Yes. What is the results? Nice, doctor. This is the crucial moment of the procedure. Thank you.
Okay, Dr. Hashish, I think you have an opinion.
Yes, I would just like to add to what Dr. Eugene just mentioned. Ideally, a DSLR, digital single lens reflex, should be used with an external flash, what Professor Miyake actually does. The external flash is rotated 180 degrees and it faces a white ceiling, and the DSLR is on an auto mode, so that without much expertise one can do that. I don't use an external flash, but I have settings in my Phlebo suite where I have the same light arrangements for every patient. And as Dr. Eugene rightly said, it is a most crucial part of CLACS technique because there is no other objective evidence of improvement. And in fact, there has been a paper by, if I'm not mistaken, Santiago et al. In 2018 phlebology regarding the patient satisfaction being improved, the perception being improved after they were showed the pre and post treatment photographs. So yes, photo documentation has to be very particular. In fact, it is said that we should have at least 20 pre-op and 20 post-op photographs.
Great.
Okay, there is just one comment. I have also the way that I've been using, I have two iPads, one on one side and the other at the other side, and I show the patient in two iPads the difference, after and before, Besides that, I have a bigger camera also. Does any of you use that kind of exposure, or just you show you in your computer, or you have an extra TV where you show to the patient the photo documentation?
I basically show it on the, I have two 21-inch LEDs side by side, and I show it on them.
We have very nice question from Mark Whitley. He is with us. He said his question to Victor, can you use the duplex scan instead of vein viewer to assess the result? That's a question from Mark Whitley.
There is a new kind of proof with 10 to 12 megahertz of resolution. With that kind of special proof, you are able to see the feeder veins. That's why I show when in the previous slide that duplex scan has to be done by the doctor who is doing the treatment. We must learn, we have to improve, and we must have the new kind of pro who just will help you us with that kind of question that Mark asked us. We can do it, we can see it, and you can work without trouble. And this is a sclerotherapy under or echosclerotherapy is another very nice talk that we will have in the future. Felipe?
Okay, there is another question from another question from Professor Rashad Bishara, one of the famous phlebologists in Egypt. He said, "Do you have experience using etoxysclerol or STD in CLACS?"
Yeah, this is this part is just for photo documentation. I will show in a little bit further the next stuff, and we will create that for Dr. Bishara. Okay, give my regards to him, and I will talk and I will show him what is the difference. Okay.
Okay.
Okay, I will go. There is some more comments from the panel.
Okay, let's keep it for the next
For the
stop,
next section.
Okay, let's keep going. Fine.
Yeah, keep going. Yeah.
Okay. Okay, when we are talking about how we do the treatment, the treatment has 4 steps. The first one, you must see the veins that we are seeing up from before with augmented reality, with the visualization of the feeder veins. You might do it if you like it by the sonogram machine, but it's a little bit tricky because with the vein viewer it's easier, and you can do it by your nurse who will help you in the office. Then we do the application of the transdermal laser energy to the feeder veins and helping always in the overall with the telangiectasia that we see around. And the third is the injection of the sclerosing agent in the feeder veins. We usually use always to the cooler device that is the Frido, who will put the temperature of the skin just a little bit down to have a better result and helping with the sclerotherapy and help us with the laser. I will show you, this is, I have from my panelists, I have some videos, and I would like to show you the way that we are working. This is from Dr. Galbao from Brazil. Something that you don't see, you're able to see after the vein viewer. Okay, this is another video from Dr. Galbao Alvaro. He's showing us how to inject, okay? Okay, this is the way that we see the feeder vein. You see, we are just looking at where is the hole and trying to find out where is the problem, and trying to, after this, trying to fix it with the laser. Over here in the left picture, you will see a feeder with 2 small veins that are coming out over there. That one, we saw that the feeder vein is coming from up, from down. The other one, the last picture, is having the same. Okay, how we do the laser treatment? When we start doing the laser treatment, we cook the vein with the ND-YAG, and the ND-YAG T64 is give us a selective absorption of the light and the hemoglobin, hitting the blood inside and giving some damage to the basal wall. After we damage the basal wall, we put the vein wall, we expose the vein wall to the sclerosing agent, and after this, we do the sclerotherapy. How is the fluency, the spot, and the pulse width? This is the way that we are working. We use 6 millimeter spot size with a fluency of 70 joules and a 15 millimeters. This is the Fredo machine, give it the frozen air, and over here you may see how we are giving just a small, tiny touch of the laser above the skin to try to reach the vein, and then just a little bit touch, not too much. We are not, I will repeat the vein, you see, we saw the vein over there, 2, 3, we're repeating again. It's not too much, you see. There is another one over there. There is another, okay. This is, I will show you more laser, okay. The same stuff, 6 millimeters spot size, 60 joules, 15 pulse width. Look, we are trying to do the same. The Fredo is working, frozen the skin. We saw the vein and we are giving just a little bit touch of laser. 2 or 3 passages over the vein just to cook the vein and to expose, to give some exposure of the intima to, after this, give the last shot of the sclerotherapy agent. Then, after we do that, we go to the next step, that is the cryosclerotherapy. And the cryosclerotherapy is the treatment of the varicose vein by the injection of one irritant that causes inflammation, irreversible damage of the basal wall. When we start, the original clocks deliver 75% of glucose, but I also recommend glucose of 50, and I've been using STS and polidocanol in very small percent, and we have as a foam the same result that we have with the glucose. I will show you just in a few minutes videos of that stuff. This is when you finish with the laser, you just start doing the injection of the agent of the sclerotherapy. In my way that I've been working, it just give it just a teeny one, and you see how the vein disappear immediately after the treatment. I will show you again. It's just a little bit difficult to just use the vein viewer and do the injection at the same time, because you must there is some kind of difference between the light and the way that you see. And you must follow just the image in the vein viewer to have a better exposure of your treatment. Let me show you. In the left one, we have STS or polidocanol at less amount, 0.2% after we treat it. Look, this is the injection. Just a little bit, not too much, because the people who inject the glucose give a large shot of glucose. I'm afraid of that. You see, and the results are very nice. This is the way that I do sclerotherapy, always in my office. I give just a little bit of time to know that I'm in the vein. When I see the blood coming through the point of the needle, at that point I give it the shot. And this is with the glucose 50 or 75. The glucose requires a large bore needle 27 to above. You see, when you inject the glucose, is moving a little bit slower when you inject the foam. There are people who inject more than 10 cc in the same spot. I'm afraid of that. I just give in the way that I've been using STS glycose of polydocanol, just a short amount of the agent, not too much. And then in these slides, you will see the fourth step of the clocks. The first one, the visualization through the vein viewer. In the second one, working with the laser. In the third one, you will see small amount of collapsed vein. And then in the fourth one, you will see how we work with the last shot, giving the sclerotherapy. One more time, the injection, to show you how you're doing it and how is the way that I'm working. I usually use for that moment also the Fredo, but because of the situation of the movie, if I have, when I try to take and do the injection with the Fredo, I didn't have very good images because the Fredo gives some frozen air, and the frozen air change the images for the view in the TV. Okay, this is some stuff that just bringing from my colleagues. This is the before and after of Dr. Ashish Dadas from India. You might see one before the treatment and the other one after the treatment. You see how the vein, the fissure disappear, and also the branches are going down already. And at that one, you see the before and after too. There is another video of Dr. Ashish that will run right now. You can see over there the work in the same that me. He is doing cooking the vein with the laser. And after he cooked the vein with the laser, he inject at the same time. And you see the difference, before and after, before and after, before and after. This is the way that we work, and this is done by Dr. Ashish Dadat from Mumbai. This is from Russia, Dr. Eugene Beresnoy, with the same stuff what we're seeing from before. You see, you don't see anything, and after you might see where is the feeder vein that just came from above to below, and we have to fix that vein. Now, I will have the result. This is the way that Dr. Eugene works. He is cooking the vein. He has the Fredo working over there. And after he finishing that, he inject with the he's covering. Set the Alma laser, the 1064 laser. He's working, cooking the vein. And after this, he gives the shot of glucose. He's covering the skin, and we will release the patient after this. Okay, at that point, we show almost everything. We show the tricks. We show how is the way that we are working. I would like to have the panel questions and comments.
Great, it was very nice. Very nice and a very interesting presentation. Really enjoyed all these films.
I would like to welcome Mark Whitley to join our platform as a panelist. And we're very eager to join his meeting in April in UK. You can open your mic, Mark, and tell us what happened to your meeting and tell us your feedback.
Unfortunately, COVID happened, as we all know. I would say that was a fantastic talk, Victor. Really, really nice talk. And I've wanted to know more about CLACS for some time. I've seen small presentations before, but I've not seen such a clear presentation. Can I ask some questions?
Yes, sure. We are ready for the question. I would like to have also, besides of Mike, also, I would like to have the comments of the panelists from Brazil, because those are the guys who develop and we will start with that stuff.
Yes, Casey has already answered one of my questions online, which is lovely of him. And I'm fascinated by the understanding of this. When you're firing the laser, are you firing in just certain places, or are you running along the laser like a chain of pulses?
Can you repeat it again? I switched my earphone because it was too loud already.
Sorry, yes. So when you use the laser first in CLACS, do you fire in just certain points on the vein, or do you fire repeating along the vein?
Yeah, we're trying to shut when the feeder vein come out. This is the first spot that you usually trying to get, and then you are going around trying just to unveil and give some exposure of the intima of the vein, to just cook the vein a little bit to have an increased amount of results after you do the sclerotherapy. This is the idea.
So you don't have to cook the whole vein, it's just certain areas, then the sclero.
You see the videos. I will set it up, and again, if you like to see it. You will like to see it?
Thank you.
Ready to see the videos and again? I will go backwards. Because you see, I will go backwards and again. I will show you the way that I've been working, I will show you the way that Eugene is working, and the way that, you see, the feeder vein start over here at that corner. This is the first one that we shot. Then we are trying to find out where are the other veins that they are large, and we shoot over them. You see that point? Okay, I will show you the way that is working, is doing it Ashish in India.
So I think Mark is saying, do you do the laser every 3 millimeter or 4 millimeter? I think Mark wants to know the science behind your selection point for laser fiber. Is that right, Mark?
Absolutely.
Yeah. Can I reply to it?
Yes, please.
Yeah. Hello, sir. So basically, your question is asking as to do we cover the entire length of this vein segment? So we are using a 6 millimeter spot here. So that basically means that the laser is covering 3 millimeter on either side of the point. So actually, for instance, if the feeder vein is 15 millimeter in length, so usually we would like to give 5 shots. So because 3 millimeter on either side, and if the vein does not respond, then we can do a second pass. So that would be the answer to your question. So we do cover the entire segment, but then 3 millimeter on the either side because it is a 6 millimeter spot.
Thank you. And in that one you've just shown, Ashish, a very nice one on the front of the tibia, did you just use CLACS, the laser bit for the underlying feeder, and no laser on the surface? The surface is taken by the sclerotherapy?
No, sir. The laser is applied both to the feeder vein as well as the surface vein, the telangiectasias. It doesn't work that way because basically CLACS is all about synergy. The laser damaging the vein wall, causing the vein lumen to collapse, and the sclerosin getting trapped inside the collapsed vein segment. And that is how the synergy is produced. So whether it is the feeder vein or the telangiectasias, we need to use both.
You're not seeing any depigmentation of the skin from the laser?
Sir, we do get some amount. I do get some amount of bruising, which ecchymosis for a period of say 2-3 weeks, but it resolves on its own. But in my cases, I'm yet to find a pigmentation which has lasted for more than 2 or 3 months.
So, but you don't burn the skin. You don't get a white patch from the laser.
No, because we are protecting it with the cryocooler, the minus 30-degree air. That protects the skin.
And one final question, I know I'm hogging this, but I'm very interested. One final question is, did you use compression on that case you showed us?
No, if a patient is only is undergoing CLACS, no compression. At least I do not use any compression.
From my point of view, I think one of the biggest advantages, which I didn't realize till today, is the lack of compression. Because every one of my patients hates compression, and they all say to me, if you could stop using compression, I'll send all my friends to you. Compression is the thing that everyone hates after sclerotherapy, and of all the things I've seen about CLACS, that's probably the biggest message I've seen today.
Okay, Victor, I have some question. Thank you, Mark. Really, I enjoyed your comments and the questions. I have some questions from the attendees for Victor and the panel. One of them asking about, do you have one type of laser? You use Nd:YAG laser 1064. And another question, do you think using cooler, this is from Swat Dogansi, asking about the using of the cooler, does it induce a spasm of the venule and make it more difficult to cannulate? And another question from Wasila, Dr. Wasila from Egypt. She's a very famous phlebologist in Egypt. She's asking about the photo documentation, and also from different fellows from India and from Tiram, asking about it is not possible to make photo documentation in some countries. Can I get this quick answer for this quick questions? The type of laser and
Ayman, let me stop them. You know, that is not true. They have very nice cell phones, and if they take a picture with a cell phone, sometimes it's enough to just clear everything as a photo documentation. You don't need sometimes a special camera. You just need a very good light and just shot your phone over the area where the vein is already to show the patient the results. This is the idea. In aesthetic phlebology, we change the view, and the patients are very special. They will like to have the results. There are people who self-pay for everything, and they would like to see what they are doing for them. This is a new technique, and the people would like to see that they improve it as soon as you can. Eugene, what do you think? Can you answer the question that Dr. Ayman said?
Type of laser and the use of cooler.
Cooler, yeah. We use the cooler for the both reasons. The first one is during the laser, we decreases the pain of the skin. And the second reason, we protect the skin. And also the cool air enhance the effect of sclerotherapy. And we usually using the sclerotherapy in the vein which are not closed after the laser, just open segment of the vein, we need to use the sclerotherapy, not all of the feeder veins. After the laser, we have the collapsed. This is the sign of the photothermolysis. The most of the vein closed, and we need to put the sclerotherapy, the dextrose, only in the segment which are opened still. That's This is the reason why we're using the cooling air. And concern the sclerotherapy, and I like this comparison with the clocks. With the when we're using the clocks, we can use in the sclerosant. Never. The Kazuo Miyake said he never done the sclerotherapy, and the invention of this technique, clocks, its acronym, was invited him. Not cryo-laser cryosclerotherapy. You can do the cryo-laser cryosclerotherapy with the STS or polydecanol, but it will be not the clocks. Clocks never do the sclerotherapy. That's why you can't use the stockings that the Mark said. My patients hate the stockings. My patients too, because I'm living in the south part of Russia, and the people hate about the stockings. That's why I'm choose the clocks without any sclerosant. You know, the more general effects after the sclerotherapy, it's a matting or hyperpigmentation. That's why we need to use the patient need to use the stockings. We're not using the stockings with the clocks. This is all safety procedure. This is not needed the stockings. That's why we're not using the sclerosants, only dextrose and laser. And the second point about the cooling, I'm set. Thank you.
Alvaro, do you have some comments for us? Alvaro.
I have a comment, very great comment from Kazuo Miyake. I want to read it because this is the very, very, very famous guy.
He is the one who make it. He is the one who we learn. Everybody learn from him.
Yes, exactly. And he has written,
actually,
he had written a very nice comment. I read it as it is. Congratulations, Professor Kanata and Ashish. Very nice experience and presentation. Perfect result. The most important part of CLACS is the synergy. When we perform sclerotherapy, the vein telangiectasia is already pre-cooked by the laser. Dextrose 50% is weaker than detergent and other detergents, but powerful enough to finish the job. Some extras, the high velocity, avoid skin ulcers, and dextrose come over.
Okay, Alvaro, do you have some comments for us? Open your mic, please. No te escuchamos, Álvaro. Ahora. No te escuchamos. Álvaro, you have to improve. Luis Fernando, this is another point that I would like just to clear and you recall you. There is some point of the quality of life. We ask the patient if they improve after the treatment, if they feel that the heaviness and the swollen and the complaint that he have in the left are improving. And there is a very nice talk of Diane Albernas and Dr. Albernas regarding about that. Can you tell us, Luis, how is going on in that area with the quality of life and the way that we are working those patients in your area in the Albernas clinic over there in Brazil? Luis.
Hello, everybody. Are you hearing? It's a pleasure to be here. Thanks for the invitation. Yes, last year in the Dream in Italy, Diane has presented the oral presentation about SIP1, CLACS, and quality of life. And we had 49 patients evaluated, 96% feminine, and we compared before and after the quality of life Aberdeen score before and after CLACS. And the median before was 11.7 and after 5.8. So we had an improvement of quality of life measured by Aberdeen score in patients therapy. And we found statistical significance, and we are prized with third place at Congress. And I guess it's a way to contribute with your brilliant presentation. And we are very proud to be here because we follow Razumiaki since the beginning. And we usually do plaques as our main procedure in our clinic.
Okay,
Alvaro.
I have another comment.
Alvaro.
Dr. Ayman.
Okay, you have already, your mic already working?
Oh, please.
No, it's not working, fine. Okay, let's go through. Ayman, just follow through. And you want me to go through?
Yes, okay. There's a very great comment, and I have, I think many comments will follow this one. It's also from Kazo. He is telling us, I perform always recommend overlapping by laser shots by 1 to 2 millimeters and 2 to 3 passes in veins and telangiectasia. You run over the vein 2 or 3 times, as I can imagine, and you overlap by 1 and 2 millimeters from each spot.
Ashid, can you answer that?
No, this is comment by...
Oh, it's a comment.
Sorry?
Okay, fine. But how are you doing it?
Yes.
Sorry, I'm sorry, sir. I was typing an answer. I'm sorry.
Yes, Kazo is saying he performed laser shots by overlapping 1 to 2 millimeters from each and run over the vein 2 to 3 times.
This is an answer for Mike Widely, who asked us if you're going back and forth over the vein. He sometimes, Katsuo, sometimes is overlapping the shot and he's just cooking the vein when he's feeling that he required just a little bit more. You will see how improvement of the vein after your laser shots, and you will see with the vein viewer that a little bit of shrink of the vein after the treatment. Okay, might I go further? There is more comments, Ayman?
No.
Okay, I will go through.
Yeah, sure.
Okay, let me go finish the last part.
Sure.
Okay, the idea right now is just give it to you the pills for the young one, and I would like to know what is going on. The old phlebology room has to be changed for the phlebology suite. The phlebology suite has to have everything. The new wave in phlebology came because we have the laser, because we have the new machines, we have the sono in our office, and we are doing everything for the patient in the same place. You must have the laser setting and a spot of 6 millimeter with a fluence of 60 or 70 with a pulse width of 10 to 15 microseconds. The second one, always you have to remember that the cosmetic patient are different than the regular patient, and the patient require always the truth. If you want to repeat it, just repeat it again and trying to give and tailor in the way that the patient requires. This is your idea, and you will have a better results since you tell the patient how much the improvement that he has and how you feel that the treatment is working. The third one, show the results as soon as you can. And usually, I have the first shot of pictures at the first time, and after the second time, when they came for the second treatment, I show whatever we have already. And the improvement is amazing. You will have an improvement more than 50% after the first treatment. After the second treatment, you will have an 80% and always more than 80 after the third treatment. Photo documentation, as we talked before, is the key. And you may see in the result over here, this is a large vein after the first shot and after the second shot, after the third shot, and we give in that moment, after the 3 passages of the laser, we give the sclerosing agent, and we have the very good result, and almost the vein disappear. The same one that you will have another one. There is a large vein that came with a feeder vein from down from below, coming the first passage, the second, the third, and after the fourth, you will see that almost the vein disappear. And these are the clinical results that you can see. You see the vein over here. Usually the patients are very special, and you see over here, you see the vein, over here you don't see anything. This is a much large veins after the improvement of the class, before and after. Then you will have a large veins. This is a very difficult patient because the skin is dark and you can burn with the laser. You have to be very careful when you have that kind of skin, because you can fail in that kind of patients. Then you see this is a large vein with a feeder vein. After 2 or 3 treatments, almost 80% disappear. You will have the other one over here. You see this is a large, small veins of telangiectasis with a feeder veins. Everything disappeared after the treatment. What are the complications? Yeah, what are the complications? The complication as discomfort, bruising, pigmentation, and swelling. And the final comments are that the CLACS, the laser plus sclerotherapy, is a cost-effective therapy for spider veins in face and legs. Just to remember, this was the size of the fish before the laser in my office. And right now, it's like this after the laser. You must remember, this is the difference, okay, before and after. You must remember that the investment that you do to have all the equipment, the laser, after 1 or 2 years is coming and make you a big difference. The system works in all the aesthetic patients and have to be mastered. We need to have, from now on, there is just 2 or 3 papers that just came from the Sehim Clinic and Dr. Miyake, who is mastering with a very nice course. We're supposed to have a meeting, and we are working, trying to, if COVID let us to meet in May in Brazil with the 10 IMAP. It will be a very nice session, and I highly, to all the members of this committee, to go over there, meet Dr. Miyake. He's an excellent teacher, and he's teaching the system very well. And the system has to be mastered, and we have to have the very best workup. And for the final, I would like to show you something from one of our friends, saying something. Oh.
Do you listen to me now? No, yes.
Oh.
Now you listen.
Okay, this is the end. Thank you very much to everybody. The president of the state saying that he's the only one who knows the system. I think we must master our system. We have to, I have people from USA, India, Russia, Brazil, and all over the world. Thanks always to Dr. Kazuo Miyake. He is the master of this. We are trying to show part of our expertise. Now I would like to open the dialogue to all of our panelists to have the final impression and try to just join together in the way, trying to fix the way that we are telling and curing our patients. Thank you very much to everybody else, and muchas gracias a todos.
Okay, thank you very much. That was fantastic, and muchas gracias. And if we can ask all the panelists to give a few words as a nice closer to this session. Each panelist can open the mic himself and welcome Loyal Kapnick to join us from United States. So let us start by Dr. Ashish.
Thank you, Professor Victor. It was a wonderful presentation. It covered almost all the aspects in the time given. I would just like to, and I was wanting to do that for some time now, was a word about the use of STD or polydecanol in CLACS. And I would agree with Dr. Eugene I personally would not prefer using any type of detergent sclerosant. 50% dextrose works well. After I had my training with Professor Miyake last year and I started, majority of the times the question is whether dextrose really works, and I can tell you that it does work. In fact, that was the reason why Clax was pioneered by Professor Miyake, because the detergent sclerosants, they can cause ischemic ulcers due to the venous capillary reflux theory. There is a paper by Professor Hiroshi Miyake. So personally, I feel Clax is definitely a promising technique. There are a lot of questions whether the cost is validated, whether how the 75% and 50% work, whether it is as good as sclerotherapy. Further studies are definitely needed, but it is definitely promising new technique on the horizon.
Okay, I'm Professor Mark Whitley. Closing remark.
Hi there, thank you. Just as a closing remark, I think that's one of the best lectures I've listened to for a very long time, and it's certainly one of the few that's going to change my practice, and I look forward to starting Clax. And thank you all.
Okay, and Philip Mamprim, closing remark.
Yeah, thanks a lot for inviting in. And for those, mainly for those who are beginners, I think the spasm and the disappearance of the vein doesn't have to be a major concern, because if you cook the vein three or two times, the vein will disappear. If you wait about 20 minutes, the vein will disappear, and you don't have to be concerned about the prompt disappearance of the vein. The idea of cooking the vein is the way to go of the whole process. And when you cook the vein, you trap the sclerosant and you enhance your results. So don't be concerned about the full disappearance of the vein right away. Just to have some patience, and the vein will disappear after all. Thank you, Victor. Congratulations for all.
Okay. And Professor Mahmoud Salah, closing remark.
Thank you very much, Victor, for this very nice illustrative talk. It's always nice to hear from you. I just have one question, one actually practical question, because I completely agree about the photo documentation and that you have to take some pictures for each patient, each visit. So, but after some time of practice, you will have thousands of pictures. How you archive them?
This is a very nice. I have 4 computers over here regarding my desk, with too many pictures, but I just keep looking down and putting up like an archive with everything, because the problem is like this. I've been practicing for more than 20 years, and the people come, we got the last shot, we show them, and you might see in my back over there a big screen TV, a 50-inch TV. In each room, there is one of them with a small computer with large capacity, with storage. We storage all of them. We put everything in folders, and we have we taking care of all those. Very nice. This is very good question,
Okay.
Thank you very much.
Professor Loyal Kabnik, closing remark.
Yes, thank you very much for the opportunity. Victor, I've heard your talk before, so I really appreciate your knowledge base on Clax. In the United States, Clax is not very popular at this point. As you know, it takes a significant investment to have a laser, to also do sclerotherapy, but there's a couple of things that we would like to know. Number one, has there been a comparison trial between sclerotherapy and Clax? Number two, there is a competing method with Clax where they do sclerotherapy and then finish with laser. Why do you believe that laser should be done first before sclerotherapy?
Ashish, you will go, okay? You will answer?
Yes, you can answer, yes.
Yeah, sir, the answer to that question, why sclerotherapy would be first before, the laser would be first before the sclerotherapy is, the idea is to cook the vein and cause the vein lumen to collapse, and thereby helping the entrapment of the sclerosant in the vein. and increasing the synergy between the two. So that is one reason. Secondly, and somewhat practically, if we take the puncture first, the blood starts oozing and then we have to put the cotton pellets. So once we do that, we cannot apply the laser. There's a second one. And the third reason would be, and again, it's a minor one, but still, after puncture, the laser tip is not sterile. So we do not usually touch the skin after the puncture. So those are the three reasons why we generally prefer doing laser before the sclerotherapy.
Thank you.
And we'll take a final remark from Dr. Alvaro Galvao.
Yeah, okay. First of all, I appreciate the opportunity to participate in this meeting with excellent professionals, and we can discuss interesting subjects. Even in the times of coronavirus here in Brazil, let's not forget the science and the parts of our daily lives. And I want congratulations to explanation for you, Victor Kanata.
Yeah.
And in relation to CLACS, we have to understand that technique that has been carried out in many places in the world and is very well accepted. Science combines two methods, laser physics and glucose chemistry. And many vasculars here are already being associated for foreign chemistry with polycanal, with laser, with good results. We have had experience since 2012, and this process is proving to be excellent. And every day we add new methods such analgesia with the fentanyl or nitrous oxide. What we look beyond the science is comfort, is safety to the patients. The CLACS technique is a technique that brings added value due to high investment we make. And the patients who pays for these services pays very well. And we have some investment, is very expensive devices. And the patients, we want the comfort and very comforted to this work. In second place, very important to know the patient's disease to choose this treatment. The CLACS will work very well for telangiectasis and feeder veins up to 2 millimeters of diameters. Above this, it will able to close the veins, but we have to, if this is very large, we have some microcoagules. Well, you show this flap suite is very important. This is necessary to complete the fab suite to have good work. Well, and finally, I appreciate the opportunity to participate and encourage this technique.
Okay, thank you very much. That is great. So we'll go to the final poll to take the opinion of our attendee. If we can put the poll up. The poll, the right percentage of cotton in garment material to make thermoregulation and to have a good patient compliance. Is it A, not necessarily at all, and synthetic material product is sufficient? B, important and should be at least 50%, or C, natural cotton with 10 to 15% is the recommended percentage to avoid with condition and growing bacteria. If you can submit your question, and let me take the opportunity to thank all the panelists for their time, their contribution, and let me invite them to join us in this weekly platform. And let me invite everyone, because the month of Ramadan is going next week. So instead of Friday, our next meeting is Wednesday, which is 22nd of April. 3 fascinating venous and arterial lecture, and we'll announce on our Facebook page and Facebook group these lectures. If we can have the result before we finish the Congress today, if we can see the result of the poll.
Okay, Omar.
Yes.
Okay, as you see, natural cotton with 10 to 15% will be the recommended percentage to avoid a wet condition and growing bacteria. Before we go, I have just final comment. I would like to thank Sigvaris company, Sigvaris Group, because they are supporting this session and give us the opportunity to be here with you today. They made a very good job indeed for gathering us together. Also, I would like to thank the company of Prime Partner, because their technology and sophisticated way to keep the project going. I would like to thank all eminent speakers that joined us today. I also thank all the panel, and it is a great opportunity to get all this panel. We have about 20 great caliber panel. I think it rarely happens to have 20 eminent professors in one panel with these great speakers. And I finally want to thank all the attendees. We have more than 220 following us during this meeting, and more than 20 others following us on the Facebook. Thank you, and see you on Wednesday. Please keep safe, and see you again on Wednesday.
Okay, bye-bye to everybody else. Thanks to everybody.
Stay safe.
Thanks.
Be healthy.
Be safe. Okay, healthy. Thanks for everybody. Thanks. Bye-bye, guys. Let's leave.
Ready?